Good morning. My name is Emily Lippert, and I am Program Manager at the American Brain Tumor Association. We want to thank you all for joining us on the web today for our online educational regional patient and family meeting in partnership with Moffitt Cancer Center. I would like to thank Moffitt for partnering with us for our second annual meeting. Additionally, I want to thank our Program Planning Chair, Dr. James Liu, who is the Assistant Member of Neurosurgical Oncology in the Department of Neuro-Oncology at Moffitt Cancer Center, for all of his support during the planning and execution of this meeting. I would like to thank all of our speakers for taking the time out to share their insight and expertise with us today. Additionally, thank you to our presenting sponsor, NovaCure, and all of our advocate sponsors, Orbis Therapeutics, Intengor Foundation, Boston Biomedical, GT Medical Technologies, and Navio, as well as our funder, Genentech, for their support of this virtual event. Without the time and effort from each of these individuals, we would not be able to bring you this quality educational programming that has brought together the brain tumor community. I would now like to welcome our Program Planning Chair, Dr. James Liu, to say a few words.
Thank you very much, Emily. Good morning, everybody. I am very happy that you are all able to join us today for our second regional patient and family meeting, sponsored by the American Brain Tumor Association and Moffitt Cancer Center. I'm incredibly honored to represent Moffitt Cancer Center as the chair of today's meeting. First of all, I would like to thank the American Brain Tumor Association for allowing us to host this meeting in conjunction with them. In particular, I want to thank Emily and Ambreen, who you've heard from just now, for their incredible efforts in putting this meeting together. We are all in an environment which we are not accustomed to, and converting a meeting over into a virtual meeting took a lot of work, and they have worked very, very hard to make sure the meeting goes smoothly today. And so I want to thank their efforts for putting together this meeting. The idea of this meeting is to provide education for brain tumor patients and their families. One of the things that I am inspired the most about brain tumor patients is the strength that they have when they deal with their disease and the treatments that come along with it. This strength is something that I imagine patients with brain tumors don't know they have until they have to deal with the situation, but they all find it within themselves to deal with this course. But what you don't have sometimes is some of the education and the knowledge about what to do in some of the situations and support that you may need and could help you along this path. And I think that's something that us as healthcare providers can provide. And I think that's the most important tool that you can have is education about the disease, about the treatment course, about what to do, and primarily about support resources that you have and how you can better deal with these situations. I think that's the idea of the conference today, is to try to provide some educational tools and information to understand brain tumors, the treatments behind brain tumors, and really to understand why your healthcare providers are doing the things that they're doing, because I think that's the most important thing, is to really understand your disease and be in charge of it. You know, and then we know that there are many parts of this treatment course, some that we don't talk about, and one of those is the financial aspects of it. And at the end of our conference, the last session, we're going to talk about some of the financial implications of having a brain tumor treatment. And hopefully you'll be able to come away from this conference with some information that'll help you in this, in your treatment course. So again, I'd like to thank the American Brain Tumor Association for allowing me to be the chair of this conference today in representing Moffitt Cancer Center. We hope you all enjoy this meeting that we put together. And next, I'd like to have the program leader of neuro-oncology, Dr. Michael Vogelbaum, say a few words.
Well, thank you, James, and good morning to everyone. It's really a pleasure to have you here at the ABTA and Moffitt patient and family meeting. And as Dr. Liu said, the first time we're doing this virtually. And I hope that you will really enjoy this program and gain a lot from it. I'm also welcoming you on behalf of my partner in leadership, Dr. Peter Forsyth. At Moffitt Cancer Center, our mission is to deliver multidisciplinary, very specialized care and comprehensive care to patients with all forms of cancer, and in the neuro-oncology program in particular for patients with brain and spinal tumors. And this involves both the latest state-of-the-art clinical management, including especially clinical trials, but also to provide general support to patients to help them manage this disease. And ABTA has been a tremendous partner, I think, in helping to guide patients, help them to cope with this disease, and also to help sponsor some of the important research that's going on in order for us to find more effective cures for this. So I hope that you really will enjoy today's program. Thank you to Dr. Liu for all of the work he's done to put this together. And with that, I'll turn this back over to Dr. Liu. Thanks, James.
Thank you, Dr. Vogelbaum. Next, we'll have Mr. Ralph DeVito speak a little bit about the American Brain Tumor Association.
Thank you, James. Thank you, Mike. I want to welcome everyone to this morning's and afternoon's very exciting regional meeting on behalf of the American Brain Tumor Association. Thank you to our sponsors. Thank you to the Moffitt Cancer Center, in particular, Drs. Vogelbaum, Forsyth, and Liu for your hard work and your partnership. Next, if you think back, and one more, please. If you think back to how things were when the ABTA was founded around 1973, and no one is satisfied where we are today, but looking back, it was pretty bleak. There was no coordinated funding of brain tumor research. There was no medical specialty dedicated for brain tumor treatment. There was no national tracking of incidence and mortality for all brain tumors. And the ABTA was a key driver in the creation of the Central Brain Tumor Registry of the United States. So today we have that tracking that's available to researchers, clinicians, and the general public free of charge. So there were significant gaps. Next is our mission. Some of you may not know that the American Brain Tumor Association, founded, as I mentioned, in 1973 by two mothers who each lost a daughter, a very young daughter, to brain tumors. Our mission is to advance the understanding and treatment of brain tumors with the goal of improving, extending, and ultimately saving the life of everyone diagnosed with a brain tumor. And how do we do that? Here are the areas of focus. Let me say now, and I'll probably say it again a couple of times, abta.org is the place to find all information about brain tumors and about the work of the American Brain Tumor Association. You see that we focus primarily on two big things. First, our legacy is funding research, and second, supporting the patient and caregivers as they are diagnosed and go about their entire brain tumor journey. Our goal is to provide best-in-class patient and caregiver support, education. We serve all tumor types and all ages. And how do we do that? Let's just briefly, we have a limited time. Next slide, please. And the next slide is about research. So since we were founded, we have proudly invested over $32 million in brain tumor research. We fund research primarily in the US, but we also fund breakthrough research opportunities around the globe. And we could not do this without the expert panels of scientists that volunteer their time to review and score the research proposals that come in, with a primary focus on those early in their career. Speaking of which, the next slide talks about something we're very proud of, and that's our Alumni Research Network. We bring together every year for 2.5 days those who've been funded by the ABTA and that are early in their career as researchers. And so it is, as you can see on the screen, this was last year's gathering in Chicago. We normally gather for 2.5 days in person. This year, the meeting, of course, like so many meetings, are moving to a virtual platform, but we're still excited about bringing this group together virtually. They'll collaborate, they'll learn, they will share their experiences. In many cases, they'll jointly apply for additional grant funding. Next. In addition to directly funding research, we also collaborate. And let me just illustrate one of those collaborations. It's the Brain Tumor Funding Collaborative. There are 6 nonprofits, 5 in the US, 1 in Canada, that come together, and every few years we pool our money and we fund larger brain tumor research than we could normally fund individually. Most recently, we pooled $3 million and we funded 4 brain tumor projects, and we're going to hear in September virtually from those 4 funded teams their work as they are looking at immunotherapy and primary brain tumors. So as I mentioned, research is our legacy, but we believe, the best-in-class patient services. And all of our programs and services are offered free of charge, and we could not do it without the generous support of individuals, corporations, including today's sponsors. Next, please. As I mentioned, we're very proud of our website, and it's continually updated. ABTA.org. We have a brand new, was no longer brand new, it's now a couple of months old, on COVID-19. If you go to the top of the page, you will see COVID-19. Click on it. Go online to pursue the information. It's available at your fingertips, of course, free of charge. Next, we're also very proud, and we still produce, in addition to online, we have brochures from our widely known primer. We have a brand new publication that's about to come out on brain metastasis. So these are available free of charge to any brain tumor patient or their family. And then we provide them to institutions at a nominal cost, so we can cover the cost of creating those documents. So again, on our website, you can find them, you can ask for them. And next, we also have an in-person, a by phone or email or text opportunity to talk to a trained program manager. You met 2 of them, Emily and Ambreen. We have a 3rd program manager, Vince Rock, who leads that effort. We're very proud of that free of charge service. Please call us. We're there to help you. In addition to directly providing education, information, we can also refer you to very important services. We have a great partnership with the Sontag Foundation and the Brain Tumor Network. They're based in Florida, but they serve the entire country. And one of their newest offerings is a financial assistance opportunity for those that qualify. And so contact us or contact the Sontag Foundation or Brain Tumor Network for more information. Next, in addition to talking to someone, we have, for those that prefer it, an online platform. We have about 25,000 members in our online community, and it is completely confidential. You can search by tumor type, by subject, so it's a great resource. It's called The Connections. As I mentioned, it is very, very popular. Next, we have programs every month, free of charge. They're sponsored, and they are just wonderful webinars. And they're also posted on our Anytime Learning channel on YouTube. Coming up Wednesday of next week, Dr. Patrick Wen, who some of you know Patrick, and those of you that don't, he is just a renowned expert talking about late treatment effects and survivorship. Next, we have programs like this. Normally they're in person. We normally have 4 regional meetings around the country. Our New York meeting was moved to a virtual meeting very quickly. And James, thank you for recognizing the wonderful work of Emily and Ambreen, because they just moved quickly to set up our New York meeting from in-person to virtual with like a week planning. Unfortunately, our Minnesota regional meeting had to be canceled. Today, we can't thank you, James, for chairing this effort and having this event virtually, free of charge for patients, for family members, or the general public who just need this very vital information. So we're very proud of our regional meetings, and I just really want to thank Nicole Wilmarth, who heads up our mission work, and the entire team. So those are regional meetings. Our signature patient event, next slide, is our national conference. Normally, it's in person and virtually. This year, it'll be fully virtual. Registration will open up next week. If you don't receive a link by the end of next week, please contact us or go to abta.org. It's going to be an exciting program, a lot of hard work by the program co-chairs, including Dr. Mark Gilbert of the NCI, who's one of our two co-chairs. He's working closely with our team to put on just a phenomenal program. We are going to have someone that you may or may not know who's a brain tumor survivor. Her mother is a two-time brain tumor survivor. Maria Menounos, who is an online personality, has a TV show, online show, etc., will be our featured speaker for that conference. So please, if you don't receive an invitation from us by the end of next week, please go to abta.org, sign up. It's completely free of charge. Next, we have something that we're really pleased to offer, and that is a peer-to-peer mentoring service. We have hundreds of trained mentors who we will match with a caregiver or someone who's a survivor, and you'll connect by phone or by email. So contact us, and Emily or Ambreen or Vince will match you with the trained either patient or caregiver. So how can you help? Let's talk a little bit about getting involved with the American Brain Tumor Association. We, though based in Chicago, are a nationwide organization. As I've mentioned a few times, we have regional meetings, a national meeting. We have events, signature events all over the country, including Tampa Bay. And by the way, Moffitt is one of our sponsors of that event, and we will hopefully hold it in person next March. Unfortunately, we had to postpone it this year, but I'm looking forward to it. As a former longtime resident of Tampa, I'm very proud of what we do in that market and the other 8 signature BT5Ks, as we call them. Next slide, please. In addition to the BT5Ks, we have the opportunity for you to raise money any way you wish. We will support you. We have a dedicated staff person to work with you, to guide you, to utilize our tools. We also have opportunities for you, if you're a runner, to run in the Chicago Marathon, the New York Marathon, and you can both, take advantage of that, and you can raise money for the fight against brain tumors. As I mentioned, we have BT5Ks in the following markets this year. They're all moving to, they're all going to be virtual. We're hoping that Twin Cities, LA, and San Francisco, and New York will also be in person. But as everyone knows, it is a very challenging time to try and have an in-person event. Next, we have opportunities for you to get involved through Community Connect by becoming one of those trained mentors. All you have to do is contact us, and we will train you. We will match you. We'll also work with you, as I mentioned, if you want to do an event. If you have a particular skill set, if you're a photographer or have some other skill, contact us and say that you will step up and work with us as a volunteer. And finally, very proud, next slide, of our Mind Matters. It is a monthly e-news communication. It is widely read. It is really a great source of information about brain tumors and about the work of the American Brain Tumor Association. You can see there that we're also active on social media. If you will help promote the services and the events of the ABTA, that would be so very helpful. So let me say thank you. Let me say thank you to our sponsors. Thank you to the Moffitt Cancer Center. We at the ABTA could not do what we do without you.
Thank you so much, Ralph, for sharing with us about the mission of the American Brain Tumor Association. As Ralph stated, everything that we do is to help patients and loved ones affected by brain tumors. If you love our mission, we encourage you to get involved, whether that is through fundraising, as Ralph mentioned, serving as a peer mentor, volunteering, or attending any of our events. If you have any questions at all about how to get involved with our organization or how we can better serve you, please visit our website at www.abta.org, or feel free to reach out to our info account where we can answer any questions that you have at info@abta.org. We would love to get connected with you. Our next session is our sponsor lightning round, where we will hear briefly about the resources each sponsor provides. We encourage all attendees to discuss treatment options, including clinical trials, with your clinician to determine what is best for you. The ABTA does not endorse any particular treatment option over another and values evidence-based patient and clinician shared decision-making in determining the best treatment options. Please welcome our first presenter, our partner institution, Moffitt Cancer Center, presented by Dr. Vogelbaum.
Okay, great. Thank you, Emily. Again, thank you all for joining us. And we just have a short video that tells a little bit about what types of care that we provide to patients. So if you can go ahead and roll that video, please.
Moffitt Cancer Center's neuro-oncology program provides the latest technology to treat cancer. Our team of physicians specialize in evaluating and treating patients with tumors of the brain, skull base, and spine. Some of the most complex surgeries, such as awake craniotomies, brain lab intraoperative tractography navigation, and minimally invasive surgery, are performed in substantial numbers at Moffitt. Our neuro-oncology physicians provide each patient with the highest level of personalized care. We recognize that no two cancer cases are the same, which is why we have a team of medical experts that collaborate at a weekly tumor board to determine the best course of treatment for each patient. Our robust clinical trials program gives some patients the opportunity to receive innovative treatments that are not yet widely available for primary brain cancers, such as glioblastoma or glioma, as well as metastatic brain tumors. We also offer innovative treatments such as chemotherapy infusions, experimental vaccines, immunotherapy, radiation therapy, and stereotactic radiosurgery for tumors of the brain and spine. Our neuro-oncologists are some of the most skilled in the Southeast. The high level of experience of our team not only contributes to improved outcomes and a better quality of life for our patients, it also takes us one step closer to our goal of finding a cure for cancer.
Thank you so much, Dr. Vogelbaum. Please help me welcome our presenting sponsor, Novocure, presented by Tracy Hanover.
Good morning, and thank you all very much. On behalf of Novocure, it's my privilege to be here with you, and thank you to the ABTA and Moffitt Cancer Center for a very informative regional program. Novocure is the manufacturer of Optune. Next slide, please. Next slide, please. Optune is a wearable, portable, FDA-approved device indicated to treat a type of brain cancer called glioblastoma multiforme in adult patients 22 years of age or older. Optune is small and weighs 2.7 pounds. Optune uses adhesive patches called transducer arrays to deliver tumor treating fields, or TT fields, to the location of the GBM tumor. These transducer arrays are applied to the scalp and are connected to a device and battery. Please visit optune.com/safety for the Optune instructions for use for complete information regarding the device's indications, contraindications, warnings, and precautions. Thank you again. Emily, back to you.
Thank you so much, Tracy. We appreciate you sharing with us about Novocure and the Optune device. Please help me welcome our next sponsor, Orbis Therapeutics, presented by Kartik Ayusola.
Good morning, everyone. Thanks, Emily. My name is Kartik Ayusola, and I'm the Director of Medical Affairs with Orbis Therapeutics. Today, I'd like to speak a little bit about the STELLAR study, our ongoing phase 3 trial for patients with recurrent anaplastic astrocytoma. Next slide. Unfortunately, the survival rate, no, you're right. Sorry. Unfortunately, the survival rates for patients with grade 3 anaplastic astrocytoma has not significantly changed over the last 30 years. Next slide. Patients with AA have few treatment options with limited efficacy and significant side effects. Once a patient has been newly diagnosed with AA, the current treatment protocol includes surgery to remove as much of the tumor as possible, followed by radiation and either concurrent or adjuvant temozolomide. At the time of recurrence, there are even fewer options. Next slide. While there are very few drugs approved for the treatment of brain tumors, drugs currently available all have similar mechanisms of action in that most of them are alkylating agents. Next slide. Our drug, eflornithine, is unique because while the others are cytotoxic, which means that they seek to kill cancer, eflornithine is a cytostatic agent, which means it is tasked with stopping or slowing it from growing by blocking ODC, and that inhibits cell growth and proliferation. Next slide. The history of eflornithine is robust, with 390 patient exposures with multiple phase 1, 2, and 3 trials having been completed with promising results. Next slide. The STELLAR study is a phase 3 trial looking to evaluate eflornithine plus lomustine versus lomustine alone in patients with recurrent AA who have failed radiation and temozolomide in the upfront setting. Next slide. In order to be considered eligible, patients must be diagnosed with grade 3 anaplastic astrocytoma and have currently experienced the first tumor progression or recurrence. They would also need to have completed radiation and temozolomide in the upfront setting. Next slide. We currently have approximately 250 patients across 90 centers in 8 countries, spanning North America and Western Europe. If you think you or someone you know may be a potential candidate, please speak to your treating physician. And for more information, please visit www.stellarstudy.com. Thanks, Emily.
Thank you so much, Kartik. Our next sponsor is GT Medical Technologies, presented by Corey Thomas.
Thank you, Emily. Can you hear me okay?
We can hear you just fine.
Fantastic. Well, I'd like to, first of all, thank the ABTA as well as Moffitt Cancer Institute for allowing GT Medical to partner and be part of this program. My name is Corey Thomas. I am a sales director at GT Medical Technologies and excited to talk to you about a newly approved, FDA approved and CMS reimbursed technology called GammaTile. Next slide, please. You can go next slide, Emily, please. So what is GammaTile therapy? GammaTile therapy is a safe and effective treatment. It's a surgically targeted radiation therapy for patients with newly diagnosed malignant and recurrent brain tumors. It consists of a bioresorbable flexible collagen tile about the size of a stamp that's embedded with 4 little radiation sources, or sometimes we call them seeds. The tiles are placed within the resection cavity immediately after a tumor is removed in surgery. And the tiles prevent the sources from touching the brain and maintain a proper source spacing, both protecting healthy brain tissue and ensuring a consistent optimized dose of radiation to the tumor cells or to the resected tumor bed. And over time, this tile just basically absorbs into the brain and after about 5 weeks does what it needs to do. Next slide, please. So the benefits of GammaTile therapy. GammaTile begins targeting tumor cells immediately at the time of surgery. There's no need to wait around for healing for the radiation treatment to start. Once it's implanted, it's doing its job. And the radiation is focused right where it's needed and is delivered consistently, right in the resected tumor bed where the tumor came out. So GammaTile is designed to protect healthy brain tissue while limiting the side effects of radiation. There's no need for an extra hospital stay or travel for additional ongoing radiation treatments. Treatment happens right when you get it implanted, and you can go about your daily life as planned. Next slide, please. So GammaTile was studied on patients with high-grade gliomas, meningiomas, brain metastases, and a number of other tumors. And all the patients had been previously treated for their tumors. They had a recurrence and then were treated with surgery and GammaTile. And our data is exciting. When all the tumors are considered together, patients treated with GammaTile had an average of about 9.7 additional tumor-free months in the treatment area compared to their previous treatments. So that means 9.7 additional months without their tumor coming back. So the next slide. Please visit gammatile.com for more information. We're in over 20 sites throughout the country. We'd love to hear from you, and we'll get back to you as soon as you give us an email or call us. So thank you again for the opportunity to present, and nice to meet all of you. Thank you.
Thank you so much, Corey, and thank you so much to GT Medical Technologies. And lastly, our advocate sponsor, Navio, presented by Jonathan Brown.
Hi. Yeah, it's great to be a part of this. I'm glad to be a support. Yeah, I'm looking forward to introducing Navio to you all. So you can go ahead and get started. Cool. So Navio is a really small team working to offer digital tools to just help people kind of navigating brain tumor treatment. Go to the next slide. So the way we actually got started was a few years ago, a friend of ours was diagnosed with a glioblastoma. So a small team of us kind of rallied around to just support him, sort of, navigating his own treatment. And kind of over those years, we observed how some of the things that we're doing could potentially be helpful to many others. And so that's what we've been focused on doing kind of over the last year. Next slide. So specifically, we know there's a ton to keep track of. Kind of every single day, there's a list of things one needs to do. And so we offer a digital tool that helps just keep all that organized so people can stay on track. You don't need to be thinking about, the next several months. You can just kind of think about what do I need to be doing today? Next slide. So yeah, on a daily basis, one can go in and based on a specific treatment plan that you might be on, you can kind of look up every single day, kind of these are the things, these are the times I'm supposed to be doing, and with even details to help remind of some of those detailed doctor's instructions that you might have. Next slide. Cool. And then as someone moves throughout their care, you're going to probably start different phases, and you have access to some content and helpful reminders to just help kind of reset and kind of set your expectations for what's ahead. Next slide. And so this detailed calendar and schedule that you have, again, that's specifically based on one's treatment plan, and you have access to that. And it's something you can even share with others. You can either add it to maybe your calendar, Google Calendar, Outlook Calendar, or even share it with others, loved ones, caregivers. So you kind of all have access to this complex treatment. So everyone's looking at the same thing, and everyone can work together to manage it together. Go next slide. So, if this is something that could be helpful to you, if you're trying to, manage things with spreadsheets and calendars, you can get in touch with us. We're able to kind of generate these, again, based on your specific treatment plan. Email is really simple, john@navio.com. You can also find us online. Yeah, and feel free to reach out to us and let us know how we can help. But yeah, thanks for letting us be a part.
Thank you so much, Jonathan. And I just want to say thank you so much to all of our sponsors, partners, and funders. Without each of you, we would not be able to put on this wonderful event. Our next presentation is in light of recent events. The COVID-19 pandemic has left the brain tumor community with many questions and concerns. In this brief overview, you will learn more about COVID-19, its impact on at-risk populations, and actions you could take to engage in prevention. Please help me welcome our chair, Dr. Liu.
Thank you, Emily. we'll get started here. Next slide, please. Next slide. So to start off, we want to talk a little bit about what exactly is COVID-19. I think we all know quite a bit about it. It's been in the news so much, but just to kind of recap some of the basics. COVID-19 comes from coronavirus disease 2019. It's caused by the severe acute respiratory syndrome coronavirus 2, the SARS-CoV-2 virus. This is a virus that can infect your cells and deliver their genes into your cell's genes. It was identified in 2019 in December in Wuhan, China. The main mode of transmission occurs through droplets, primarily during sneezing and coughing. Next slide, please. Now, some of the common symptoms of COVID-19 usually occur about 2 to 14 days after exposure. They're primarily fever, cough, shortness of breath or difficulty in breathing. And they can also include fatigue, muscle body aches, headaches. Another more rare but uncommon, notable side effect is loss of taste or smell. Also can be seen as sore throat, congestion or runny nose, nausea or vomiting, or diarrhea. Next slide, please. So who are at risk? And as we probably heard about before, primarily they're in elderly people over the age of 65 are particularly at risk. Also, other people with pre-existing health conditions, particularly chronic lung disease, because this is what coronavirus has been primarily targeting, but also patients with cardiovascular disease, diabetes, chronic kidney disease, as well as cancer, which is the focus of this discussion today. Now, for cancer patients in particular, the risk increases primarily, back one more slide, please. The risk is primarily focused around the idea of immunosuppression. And that is that if your immune system is weak, you are more susceptible to this disease. Now, cancer patients may have or receive or be receiving chemotherapy or be receiving radiation therapy. Certain types of cancer patients go through bone marrow or stem cell transplants. There are blood cancers that may damage the immune system inherently, such as lymphomas or leukemias, or cancer patients may be taking immunosuppressive drugs that can put them at risk. Next slide, please. So in particular, in cancer patients, we have known, there have been some studies that show that cancer patients have a higher chance of severe symptoms. There have been previous studies, particularly by investigator Dr. Dye et al. From Cancer Discovery in 2020 that showed that patients with hematological, lung, or metastatic cancer, or cancer patients who had undergone surgery, had the highest risk of severe events. And this includes ICU admissions or needing mechanical ventilations or being intubated. The American Cancer Society back in March surveyed cancer patients in COVID-19 and found out that 50% of cancer patients have noted impact in their care. So it has impacted cancer patients indirectly. 38% of patients noted that the financial situations that have arise as a impact of COVID-19 have affected their ability to pay for their care. Next slide. This is one of the figures from that slide of this survey from the American Cancer Society. And you can see here the top bar shows that 24 to 27% of patients have found that their cancer patients, their treatment have been delayed, as a result of COVID-19. And so we do know that, despite, not being directly related, the effect of COVID-19 on the healthcare systems can affect how a cancer patient is treated, diagnosed, and it's something that we need to be attuned to and be aware of. Next slide, please. In terms of treatment of COVID-19, there are no proven drugs to change outcomes. More recently in the news, you've heard some news about steroids for severely ill patients having shown some effect. In another drug named remdesivir, that's been recommended for only patients that require mechanical ventilations. But overall, no proven drugs to really change the outcomes or necessarily provide a cure. Primarily, our treatment strategy is supportive care. If patients that are mild symptoms, we isolate. Patients with more severe symptoms, we support their respiratory needs as we need to. Next slide, please. Now, how has COVID-19 affected our healthcare access? And I think that's one of the main things that affected our cancer patients. In terms of the outpatient setting, and this is outside of the hospital, a lot of hospitals and medical centers have instituted pre-visit health screening, and that's a way for the healthcare centers and the hospitals to protect themselves and their patients and their workers, and to understand that if you have any of these symptoms, that it may not be a good idea to come in for an in-person visit. Screening upon entering the facility is something that's been performed in a lot of facilities, including in Moffitt. Patients as well as workers are screened upon entering to see if they have any symptoms. There's a restriction on family and caregivers in the examination room to try to reduce the amount of foot traffic and people inside the building. And this has led to an increase in the use of telemedicine. Telemedicine has been around for a while. It's been slowly implemented, but I think during the advent of COVID-19, a lot of institutions have kind of accelerated our move toward telemedicine because of a need to try to keep patients safe, particularly cancer patients who may be at higher risk. On the inpatient side and the hospital side, there are restrictions on families and visitors in the hospital. And as you know, for cancer patients or patients undergoing surgery, this can be a very difficult time to not have families and visitors or support group inside the hospital. So this has been a very big change for patients in the hospital. Next slide, please. In the surgical setting, how has COVID-19 affected healthcare access? Well, back in May, in early April, there was a restriction on elective surgeries that are not deemed necessary or emergent that needed to be done. And so this caused a backlog of surgeries, and partly to prevent people from coming into the hospital that don't need to, putting them at risk, partly to conserve resources because we weren't sure about the resources and whether there'd be enough in hospital beds and ICUs and things like that. A lot of hospitals, including Moffitt Cancer Center, have instituted preoperative COVID-19 screening, and that everybody that needs to have surgery gets screened, and that's to protect the patients, the other patients in the hospital, as well as the healthcare workers. There's been, again, limited family and caregiver presence in the preoperative area, in the waiting area, in the recovery room, and this is, again, is a very challenging thing for patients undergoing surgery because that support is obviously very important. Also limited visitor access in the intensive care unit as well as on regular nursing floor. In clinical trials, finally, a lot of clinical trials have been placed on hold, partly due to personnel restrictions within the hospital of collecting tissue, trying to reduce the amount of, non-essential people in the hospital. And that has affected some of our ability to provide the optimal care for cancer patients. Next slide, please. So in particular, with brain tumor patients, what are the concerns? And the question is, how has COVID-19 affected particularly the brain tumor community? Well, we talked a little bit about access to healthcare and treatment decision-making. And I think this has a lot to do with it. And I think, this is what we're going to talk about is understanding how the access is limited and how you can get around some of the limited access to still get the best care possible by using alternative resources, by discussing with your healthcare providers and managing your medications so that you put yourself at a lower risk. Some of the treatments that can be affected are including surgery, chemotherapy, radiation therapy. These are all treatments that can affect how susceptible someone is to COVID-19. And that's something that we have to consider for brain tumor patients. And also a lot of brain tumor patients are maintenance therapy. This is a chronic long-time therapy, whether it's steroid therapy or other chemotherapies. They can provide immune suppression to the patient and put them at higher risk. And so that's something that we have to consider for the brain tumor community. Next slide, please. So in particular, in brain tumor patients, you have to really understand your unique risk factors. Everyone's different. Everyone's in a different stage of their treatment, whether it's getting diagnosed in the middle of their primary treatment, during the surgical time, or in the maintenance phase. And I think it's important to understand, where are you in your treatment? How important is the course? What is the intended course of that treatment that you're going to be facing, and the risk window that you're going to be in? You really have to discuss with your caregivers regarding the priority of the medical treatments and the testing done. I think we are used to being able to get the tests that we want, whether it's diagnostic tests, MRIs, CT scans, and this requires a lot of trips in, but we haven't had to be worried about coming into the healthcare center or hospital like we are now. And I think having an honest discussion with your healthcare provider about prioritizing what needs to be done and what may be able to be put off for a little bit of time without any kind of detriment to your healthcare, but may put you at lower risk of COVID-19, maybe something that you want to consider. And also, how immune compromised are you? At what stage of the care are you when the surgery can cause immune compromised state, as well as steroids, as well as chemotherapies? And I think it's important to understand that and be honest with your caregiver about where are you in that stage. Next slide, please. Brain tumor patients are a very high risk of immune suppression for a variety of reasons. One thing is steroids. Steroids are very commonly used in brain tumor treatments. They're very effective for treating symptomatic problems. And one of the things is dexamethasone or Decadron. Now, that puts you at immune suppression that can put you at higher risk of COVID-19. Patients on chemotherapy, such as temozolomide or lomustine, these are cytotoxic drugs that kill dividing cells, but that also can lead to a decrease in your white blood cell count or leukopenia. And that can put you at immune suppression and make you more susceptible to COVID-19. Radiation therapy, whether it be proton therapy or photon therapy, traditional radiation, can also lead to leukopenia or decrease in white blood cell count. And I think that's something that you need to be aware of because it can cause bone marrow suppression and put you at higher risk. Surgery in the perioperative time also puts you, your body, it stresses your body out and puts you in immune suppression. So around the surgical time, you can also be a higher susceptibility to COVID-19. And finally, tumor treating fields, another commonly provided brain tumor treatment. There has been no immune effect shown. And so that's something that I think that as far as we know, does not put you at higher risk for COVID-19. Next slide, please. So what are some of the precautions that we can recommend to our patients? I think the biggest thing is minimize exposure. I think the most important thing to recognize here is that you have to be a little bit selfish. Brain tumor patients are, because of all the things that we talked about, are potentially higher risk of contracting COVID-19 because of the immune suppression. And you really have to be aware of that and minimize exposure for yourself as a patient, right? And also people that come into contact with you. That includes caregivers and any visitors. We've been under lockdown for a couple of months, and then a lot of states are releasing some of those lockdown restrictions. And I know it's been very difficult for a lot of people to, having that social, separation. And a lot of us crave kind of going back to normal. But I think we're still trying to understand the course of this disease and how it's going to affect us as a country and as a world. And I think you have to be very careful about the contact you're having with other people. Not only just patients, but I think the people who come in contact with patients have to be cognizant. If you're going to be coming into contact with someone who has a brain tumor or maybe immunosuppressed for the reasons that we mentioned, you have to be careful of the other time that you spend outside and away from the brain tumor patient. I think ideally, one of the things to do is working home or staying at home as much as possible is kind of the distancing. One of the things that you can do if there's an issue about working at home, you can contact your physician for documentation if needed, saying that you're a brain tumor patient, that you are a higher risk because of certain things that can cause immunosuppression. Again, another thing that can allow for precaution is washing hands, and that's been talked about quite a bit. And that's kind of taking care of yourself and making sure that you try to wash your hands as much as possible for the recommended 20 seconds. Avoid touching your face, which is difficult to do, but something that can really has been shown to reduce contracting COVID-19. And finally, wearing masks. This can be a very controversial issue, as we can see in the news. But the Center for Disease Control does recommend a simple cloth face mask to slow the spread of the virus. And when you go out and are among other people and when social distancing measures are difficult to maintain. I think particularly for brain tumor patients who are higher risk, I would strongly recommend everyone to wear a mask. I think it both protects yourself as well as the people around you. And I think that's something that you really have to consider doing when going out. Next slide, please. What are some of the other recommendations I think we can provide? And I think the biggest thing is talking with your oncology team, whether you're a neuro-oncologist, radiation oncologist, or neurosurgeon, to look at your care and the phases of your care. And one of those things is to reduce the immunosuppressive medications that you're on, and particularly steroids or Decadron or dexamethasone. In general, neuro-oncology providers, we try to reduce the amount of Decadron that a patient is on because it has a lot of other side effects that we don't want you to be exposed to but sometimes you need to be on Decatron, but maybe you can be on a lower dose that we haven't put you on. And so I think discussing with your healthcare provider, can you be at a lower dose? Can you reduce the amount of immunosuppressive medications you're on and still tolerate that without an issue? Looking at your laboratory tests and diagnostic studies, if they're not critical, can we reduce the amount of visits to a healthcare center where you may be around other people, around the potential exposures, and talking with your healthcare provider about that. And also talking about where is it safest to have a laboratory test or diagnostic test? Talking to the center that you're going to, whether it's a local center or a medical center, understanding whether they are screening their patients, screening their healthcare staff to try to find the safest environment, what the precautions are taking, are they allowing visitors, or how many people are there? And I think those are the things that you can do to protect yourself and try to strategize. If you need to have these tests done, if you need to have diagnostic studies done, to try to find the most optimal place for it. And also, if you have a visit to your healthcare provider, call your healthcare provider, see if you really need to come into the hospital. Is telehealth available and appropriate for the visit? A lot of times for neuro-oncology, because our examination is so important, it's difficult to do telehealth, but as we're all learning to adapt in this environment, we can do a lot of things over telehealth that maybe we hadn't thought about before, a lot of strategies about doing examinations and getting adequate assessment of our patients. Talk to your healthcare provider to see if that's an option. And I think it's very worthwhile to do to save yourself that trip and that potential exposure. Again, this is the time to be a little bit more selfish, because as a brain tumor patient, you need to understand that you could be at higher risk. And being a brain tumor patient on medication or on treatment and acquiring COVID-19, even if you're a younger individual, may have very serious outcomes. And finally, the last point is to discuss with your provider regarding the restrictions specific to their center. And coming into for surgery or a visit, are there regulations regarding the visitors or visiting hours? A lot of hospitals have very different restrictions on that, and try to understand that. As we know, particularly around the surgery time, having family and caregiver support is so important, and we haven't been able to do much about that for a couple of months. A lot of institutions are loosening the restrictions, but I think the rules change day to day. And so being prepared to know that when your visitors can come, whether it's in the intensive care unit, a regular nursing floor, in the waiting area, in the hospital, I think can better prepare you mentally to know that when you're going to be seeing your loved one, your caregiver. But also, understanding the institution, can your caregiver or family join by telephone and video? Be proactive about that. A lot of times, for a long time, we haven't allowed visitors in the outpatient clinics, but you can call your family, put them on FaceTime, put them on video, and they can still be involved. And you need more ears to kind of hear what's going on and with your healthcare provider. And so be proactive about bringing other people in through alternative methods. Next slide, please. And so finally, to finish on a lighter note, this is a very unique situation for all of us. And one of the things that we do is try to educate, everyone, including our kids who don't understand why, we're not, going out and going to school. And so, of course, we go to the foremost educational resource these days, which is YouTube, which my kids can't, be pulled away from. And one of the videos that we found is actually sponsored by the Florida Healthcare Department. And they encourage you to protect, don't infect, or in other words, be PDI agents. And they have a couple of very simple items to do to be effective PDI agent. Just 3 things. That's wash your hands, cover your cough and sneeze, and stay home when you're sick. And I think those are very kind of rudimentary advice, but it can be extrapolated into just protecting yourself and protecting each one of us, the people around you. And you can see here, my daughter and my son, we made PDI badges, and they're proudly showing it while we're out in the picnicking. And you notice in the pictures, no one around. And so I think that's the most important thing that we have to understand, is that you have to be a little bit careful and selfish in this time, because you have higher risk as a brain tumor patient. So thank you for your attention, and I'll take any questions.
Thank you, Dr. Liu. Just as a reminder, if you do have questions, please type and submit it using the chat box on your control panel at the bottom of your screen. And please direct any of your questions to the ABTA. So Dr. Liu, you talked a lot about telehealth and teleconferencing as an alternative to coming in person. We have a question about how best to prepare for a telehealth appointment. This is something that's really new for a lot of us. Can you talk to us a little bit about what a patient can do or expect in such an appointment?
Sure. I think that, in telehealth, the first thing to think about is, the equipment and how smoothly getting the telehealth can go. A lot of institutions set up meetings with their IT team to make sure you have the right equipment, download the right software. And so to kind of maximize the time for the telehealth to make sure all the external equipment is set up and ready to go. I think being able to make sure that the patient can see themselves, and so the provider can see them and do any exams over the camera. If they have an incision, make sure they can move the camera around and see them. But I think the other thing is it's hard to sometimes, because you're not in person, you may have some questions that you forget, you kind of rushed, you feel like it's kind of a rush situation. I think you should write down the questions, the things that you want to address with your provider, in particular, the things about travel or about getting diagnostic tests or laboratory tests. Writing down a list and preparing for that and kind of maximizing that time and taking your time and discussing those things and making sure that, just because it's a virtual health visit doesn't mean it should be any different than you getting the questions that you want answered during that visit.
Thank you, Dr. Liu. Now, many brain tumor patients, they may be in wait and watch or in surveillance for their brain tumor. They might not be undergoing active treatment, but they do have scans scheduled. Is there any reason that these scans should be delayed or postponed, or does an MRI pose additional risk to a brain tumor patient? Does that cause them to become immunocompromised?
No, there's no evidence that an MRI or any other imaging would cause additional immune compromise to a patient. I think the biggest concern for imaging really is just the physical travel into the center and putting the patient at greater risk of people around them and potentially contracting COVID that way. The exam itself doesn't order any blood draws. And I think the real consideration is kind of physically leaving the house and being out and exposure that way. And I think we talked about before, it's a honest conversation that needs to be had between the patient and the healthcare provider to see, we certainly don't want to delay any treatments that needed or delay any interval imaging that's really necessary. But if there's things that are not critical or necessary, you have to weigh that just like we weigh anything else, any other treatment, the pros and cons of, the risk benefit ratio of doing something. I think that's the most important thing to think about.
Thank you. And what recommendations would you have for a brain tumor patient that might actually test positive for COVID-19? So they do have the disease. Is there any actions they can take, since there aren't really any known treatments for the illness? Is there anything they can do to take better care of their health as they're trying to recover?
Sure. I think it depends on the severity of symptoms. I think the first thing you should do is contact your healthcare provider, primary care doctor, or your neuro-oncologist, particularly, to let them know and to discuss what treatments you're on and whether those treatments can put you at higher risk because when you have COVID-19. I think the biggest, how to deal with the patients, the biggest thing is the severity of the illness. And there are asymptomatic patients or pre-symptomatic patients, and they're patients with mild, moderate, or severe or critical illnesses. And all those depend on how much treatment you need. Patients with asymptomatic or mild illness, the NIH recommends patients just to self-isolate, treat as needed. People with moderates or severe illnesses that may have more severe breathing problems or other medical issues that come up, to seek a healthcare provider. And I think contacting your healthcare provider ahead of time is probably the most important thing. Going to the emergency department may not be the best option, both for exposure for yourself and for other people. I think reaching out to your primary care provider or your neuro-oncologist and talking about it is the biggest thing. And if there's any need to discontinue any treatments which they feel is detrimental to recovering from COVID, that's something to talk about as well.
Thank you, Dr. Liu. We have another question here from someone who would like to know what are questions that patients or caregivers should be asking to testing centers where a patient might go to get their blood drawn to ensure that they're going to the safest place possible and that they're taking the necessary precautions to protect the patients.
Sure. I think this is also something that you should talk to your neuro-oncologist or healthcare provider about to see if they have any recommendations, if they know any centers that they may recommend that they feel like you can be the safest in terms of precautions. I think the things that are most important for our center to do is to screen the patients as well as their workers. Screen their workers when they're coming into work for symptoms or any signs of symptoms, and also the patients. Are the patients screened in terms of having symptoms to try to reduce the amount of people that may have symptoms in an area? Also wearing masks. A lot of places are requiring masks to be worn within the institution. I think that's a very important thing. I think particularly for brain tumor patients, that's something that should be something you look for because it has been shown to reduce the transmission of COVID-19. And finally, the amount of people, the amount of foot traffic in an institution or in an area, in an enclosed area. Less people, I think, the more potentially safer you can be. And is there limitations on visitors and how people are, kind of placed out in the waiting areas? I think those are things that you should ask the place which you're going to get testing. Have they thought about those things? And do they have precautions? And have they taken an effort to make those precautions for the safety of the patients coming in?
Great, thank you. And speaking of precautions, we understand that wearing a mask is a great precaution that you can take. There has been some back and forth about wearing gloves. Can you talk about if wearing gloves is effective at all, or should patients be wearing gloves as they're going about their day?
Yeah, so wearing gloves has not been necessarily proven to reduce transmission. A lot of infectious disease experts feel that wearing gloves actually can provide the false sense of security in terms of, touching the gloves, contaminating the gloves, and keeping the gloves on, and causing more contamination. So actually hasn't been recommended to wear gloves. It's been more of the face masks in terms of as opposed to personal protection for patients and general population. I think in terms of the hand hygiene, it still falls on the washing of the hands, the 20-second washing of the hands with soap, the use of in alcohol-based hand sanitizers. Those are still the best hand precautions that are recommended.
Thank you. Another question here goes back to what you mentioned, that a great way to protect the patient's health is to try to stay home as much as possible, but it's still important to be able to get out, exercise, go on walks. Do you have recommendations or any advice for patients that are trying to still stay active while protecting their health?
Yeah, I think staying active is very, very important, and I think it's something that we all need, particularly in this time. Now, there have been some studies that show that, depending on your degree of activeness or exercising, the droplet precaution increases from 6 feet to longer, depending on whether you're running or bicycling or cycling. I think the bottom line is we're not quite sure exactly what that is, but I think the biggest thing is that you can go for walks, you can go exercise. I think you just have to, be aware of the people that you're around, maintain the social distancing. Particularly, you can see a lot of parks now, a lot of trails have the 6 feet drawn out and show you what 6 feet distance looks like. I think the social distancing once you're out, wearing the masks when you're able to, when you're out, but continue to go out, continue to exercise, but avoid the large groups. And continue to practice social distancing. I think that's the most important thing. But exercising, I think, is a very important component of our daily lives.
Great, thank you. Another question we have here is asking about if a patient or a family member goes to a hospital or a clinic for an appointment and they notice that others are not following the necessary precautions, such as wearing a mask or not social distancing. how can the patient handle that? Is there anything that the patient can do in that situation to ensure their own safety?
Yeah, I think it depends on a couple of things. One is, what are the institutional rules? Some institutions, Moffitt being one of them, were required to wear masks in patient-centered areas where groups are potentially, together. And I think you can talk to the staff at the institution to see if they can talk with the patients or caregivers that are present and maybe not abiding to those regulations. I think aside from that, I think it's about personal protection, and spacing, having that social distancing when possible, and talking to your provider if you're not comfortable, or talking to the hospital or clinic staff and discussing your concerns and trying to, provide that social distance for yourself. I think we have to take care of ourselves in this type of environment, and that's the most important thing.
Wonderful. Thank you for that advice. Now, some patients, they may be debilitated due to their brain tumor. They may require assistance at home from a caregiver or a nurse navigator. What advice do you have for those patients? Is their caregiver still able to come visit them and take care of them? Are there precautions they need to make sure that their caregiver is taking when they do come to their home?
Yeah, that's a great question. I think that becomes challenging because a patient can kind of control their own household environment, but if they have visitors or caregivers, I think we all have to be cognizant that outside of that household area, outside of that home area, all of your contacts are potentially putting you at risk. And I think it's a discussion that you should have with your caregivers to say that, are they taking precautions on the remainder of their time away from the household or away from taking care of that brain tumor patients? And I think if they're caregivers, they want to be responsible. I think they have to consider that they are coming into contact with people that are high risk. Just like, for a time being that a lot of people weren't seeing their family members or elderly family members, because you had to take consideration to not put these people who are a high risk, at a greater risk for contracting COVID-19. And so I think discussion with the caregivers to say if that are the regulations within the work, if they're taking precautions, I think that's the biggest thing, is kind of communication and understanding that, that you're a high risk patient and your caregivers need to be cognizant of that. And also to, during the contact, during the interaction, to, take the precautions necessary, the face masks and things like that.
Thanks. I think we have time for one more question. I know you had mentioned that there currently isn't a treatment or a vaccine for this disease, but is there any anticipation for a vaccine or a treatment coming up? Can you talk about what research is being done, or what patients can look forward to some kind of control over this illness?
Yeah, so, the testing for this illness, I think is still very much in the preliminary phase. As I mentioned before, the remdesivir has been approved for use, particularly only in very, very critically ill patients. Aside from that, there hasn't been a whole lot of other things that have come out into the forefront. Most recently, this past week, steroids or dexamethasone has been shown, but again, shown to change outcomes, but again, only in really critically ill patients. So unfortunately, I don't have a whole lot of great news for that. I think people are working very hard to try to come up with these vaccines. There are a lot of potential kind of preliminary studies, and there are kind of a lot of fast tracking of studies and vaccine trials and developments. But overall, I think the best thing we have to do right now is still prevention, and a few things that we can have shown to change the course for very critically ill patients. But like a lot of viral diseases, it's more about supportive care.
And just a quick follow-up to that question. Once a vaccine is eventually developed, is there any chance that can be a risk for brain tumor patients? Will it be safe for them to use?
Yeah, I think that's a great question. I think it depends on the vaccine. The vaccine, what normally is giving you a little bit of that, a virus to try to, instill a immune response without getting you sick. And so a brain tumor patient who may be immune compromised, again, it depends on what stage of the treatment you're in, can it be harmful? I think it depends on the vaccine. I think that's another consideration that you'll have to a conversation that has to be had between the patient and the neuro-oncology team.
Great. Well, thank you so much, Dr. Liu. That's all the time that we have for questions, but thank you again for joining us and sharing your clinical perspective on the COVID-19 pandemic. I'm going to go ahead and turn it back to Emily.
Yes, thank you so much, Dr. Liu, and we truly appreciate you sharing with us all the best tips, advice, and precautions for the brain tumor community to take and to help to maintain their health and safety, especially during this difficult and trying time. And thank you for all of you who shared those wonderful questions, and I hope it was helpful to you today. We will now proceed with our next presentation, which is our Brain Tumor Board. This session will be presented by a multidisciplinary panel of experts and will operate very similarly to a real tumor board. A tumor board is a regular meeting that your treatment team hosts with representatives from other disciplines such as a neurosurgeon, an oncologist, a radiologist, and a pathologist. They use this meeting to review brain tumor cases and work together to determine the best course of treatments for patients. This session really shows you how complicated care decisions are. We've put together this mock session for you to catch a glimpse into what considerations are made in determining the best course for treatment. After the session, we will have the opportunity to ask questions. Serving as our panel moderator will be again Dr. James Liu, our program planning chair. On the panel, we have Dr. Peter Forsythe, chair of the Department of Neuro-Oncology at Moffitt Cancer Center, Dr. Robert McCauley, neuropathologist and senior member of the Department of Pathology at Moffitt Cancer Center, and as well as Dr. Samuel Chow, professor at the Cleveland Clinic Lerner College of Medicine and radiation oncologist at Burkhart Brain Tumor and Neuro-Oncology Center. Please welcome our Brain Tumor Board panel.
Thank you, Emily. Can we have the next slide? So we'll start out, and so this is just to give you an idea of what we do in our Brain Tumor Board. And institutions all across the country have, across the world have brain tumor boards, and it's really an opportunity for multiple people from different specialties to get together, and we can talk about cases. Typically, they're cases that are challenging, and there isn't a right or wrong answer for these, and then we try to kind of put all our heads together. And this is really an idea, the opportunity for you to see kind of the discussion that we have back and forth. And so we'll start out with our first case. This is a 53-year-old male who initially presented with headaches, and on imaging with an MRI was found to have a right temporal mass. He was seen at a hospital, outside hospital, and he underwent surgery for resection of this mass. The pathology was reported as a GBM. After resection of the tumor, the patient was discharged, and then he presented to Moffitt Cancer Center 23 days after surgery for evaluation for adjuvant treatment. Now, next slide. This is an idea of the MRI. On the left side is the MRI before surgery, and you can see here on the right side, on the left side of the brain, on the left side of the picture, which is the right side of the brain, in white, there's the kind of mass that kind of stands out in the MRI, and that is the tumor. And on the right picture, you can see that the tumor has been removed, and that is the after surgery MRI. Next slide, please. So he presents to our neuro-oncology team, and typically sees a surgeon as well, and as well as a neuro-oncologist. And I just want to talk about the next step. But typically, a person that comes to see us, and Dr. Forsythe is our neuro-oncologist. And so I wanted to ask Dr. Forsythe, you know, any thoughts on a patient who presents to us after surgery, about 3 weeks after surgery? Any thoughts and the next steps that he would take?
Yeah, so thank you, James. I guess one of the first questions is it a maximal tumor resection? For which I'd turn to you because we have clinic. So can you just answer that? Do you think everything's been taken out that can be taken out safely?
Yeah, that's a great question. So typically in our tumor board, we also have a radiologist who, for this particular reason, analyzes the MRIs. And I think, you know, so I'm going to serve as a radiologist today, and I would say it does look like a complete resection, or what we call a gross total resection.
So I think the next step is really to determine what the pathology shows, for which we would need Dr. McCauley, and what markers are available, as well as are there any special proteins that might make them eligible for a clinical trial, or might benefit from a drug, you know, for one of those melanoma proteins or one of those lung cancer things. So we need it to be interrogated. That's what I would do next.
So I think that thank you, Dr. Forsyth. I think the next step is to get the pathology slides and kind of reanalyze them. That's kind of our typical protocol, is to acquire the slides, even if it's resected at an outside institution. So can we go to the next slide? And we'll ask Dr. McCauley to comment on what he sees here. These are the microscopic view of the tumor.
So good morning, everyone. Thanks for allowing me to participate, and thanks to the organizers. So I've divided the pathology in this case into 4 separate pictures, which are depicted here. I guess probably for some of you, it may not be clear that these are 4 different pictures, but they have different magnifications and they're different regions of the tumor. So just to kind of give you a brief overview, there are basically 2 kinds of tumors that can occur in our world. One is the tumors that arise directly from the tissue that we're examining, so typically brain or the coverings of the brain. And then about half of the tumors we see actually arise somewhere else, lung or somewhere else, and then they travel to the brain and set up shop there. So our first duty really is to determine where this tumor may have arisen. Is it a primary tumor or is it a secondary tumor? And then once we've determined that, we try to assign sort of a family to it, a lineage, to determine what kind of cells they are, and then how bad they are. So again, briefly, the top left panel will show these are cells which have arisen within the brain itself. And on the top right panel, the reason we think that, you can see some pink around blue dots. The pink is the cytoplasm of the cells, and the blue dots are the nuclei. And all that pink is an indication that the tumor cells are pretending to be intrinsic cells called astrocytes in the brain. The other thing you can see in that top right panel is a little black area near the middle that has some granularity to it. That's actually a mitotic figure, so that's a dividing cell. Dividing cells that are intrinsic to brain tend to be bad. Why do we think that? Again, it's really in the hands of the epidemiologists. We classify things and then we try to see what are relatively benign or good things and what are relatively malignant or bad things. Mitotic activity is bad, and then in the bottom left panel you can see some gloms of cells with red dots in them. Those are blood vessels and they don't look right. They're proliferating. That's bad. And actually in the bottom right panel there's a strip of nuclei and a lot of pink disheveled stuff. That's necrotic material. And so all those 3 things are bad in this context. It allows us to establish the tumor grade, the grade, higher grade being bad and lower grade being good. The highest grade is grade 4 in the World Health Organization system. And this would be a grade 4 intrinsic glioma, or tumor of the intrinsic glial cells. We would have to do further molecular testing to determine exactly what subtype this was, but the crude approximation would be, yes, this would in fact be a glioblastoma, unless something very unusual was detected in the molecular findings. Now, after I look at the slides like this, and again, this is an outside case, we can do more with a case that we have in our hands, we can do more testing, but sometimes we get tissue sent in where we can do further testing, or we can look at the slides that were prepared on the outside and try to re-examine them to see if they have any clues. So in this case, we did get some slides from the outside. I think the next slide will show them. Next slide, please. Oh, we don't have them. Okay, so anyway, my outsider view was that the tumor was a glioblastoma. It was tested for some of the molecular findings that I just mentioned, and they're listed for you there. The critical one, the key one, is the IDH status. A tumor that has an IDH, or isocitrate dehydrogenase gene, which is normal or wild type, is actually worse than a tumor that has an IDH mutation. This one did not have any IDH mutations, so it's a bad tumor, a WHO grade 4 tumor, and we have some other findings there. Perhaps we can talk about those as we proceed, but perhaps I'll hand it back to you, James.
Thank you, Robert. I think that illustrates that how much you can get, you know, in addition to just the diagnosis of a GBM or a glioblastoma, there are so much more subcategorizations that can help us understand the tumor a little better. And that's the idea of having a neuropathologist such as Dr. McCauley in our brain tumor board. And so next slide. So now that we've kind of established exactly what this tumor is, and where the patient is, what are the treatment options? And so we can, you know, the same treatment options for pushing anytime brain tumors, surgery, chemotherapy, and radiation therapy. And so this person's already had surgery, and we established that they had a pretty good resection. We established the diagnosis, so I don't think we need any more surgery. And so what's the next step in terms of chemotherapy and radiation therapy? And so I'd like to ask Dr. Forsythe to comment on this, and then Dr. Chow, who is a visitor from the Cleveland Clinic, a radiation oncologist, I also like to have him comment after Dr. Forsythe to see, you know, what radiation options we have for a GBM that's been resected.
So the standard treatment would be to pair chemotherapy, the oral chemotherapy, Temodar or temozolomide, to take orally during the 6 weeks of radiation that I think Dr. Chow can talk to us about. It's particularly important with him, I think, because one of the markers that Dr. McCauley had up on the screen, his MGMT promoter was methylated or silenced. So that usually predicts a much longer survival than usual, and for him to be much more likely to benefit from chemotherapy. So we strongly favor chemotherapy in this section. And maybe Dr. Chow, did you want to talk about radiation, maybe?
Sure, let me know if you don't hear me too well. But in terms of radiation options, you know, we think about 6 weeks of radiation coupled with temozolomide, as Dr. Forsythe has mentioned. There are times that we sometimes think of a more truncated course of radiation, and that's usually done when a patient is not of good performance status or is older, in which case they may not necessarily tolerate a good 6 weeks of radiation, in which case we can consider doing 3 weeks of radiation coupled with chemotherapy. In terms of the modalities, oftentimes we use a linear accelerator-based fractionated radiotherapy approach. Sometimes people ask questions particularly about proton therapy. Proton therapy has the ability to focus the radiation a little bit better without necessarily spilling a lot of low-dose radiation in the surrounding brain. It's I think, still experimental to a certain degree, in the sense that we don't necessarily know if that's better than our linear accelerator-based approach, but certainly can be considered if if a proton center is available at your area. Sometimes people also ask questions about stereotactic radiosurgery, and stereotactic radiosurgery is much focused radiation. One of the concerns, particularly with tumors like gliomas or glioblastomas, is its ability to infiltrate into the surrounding brain. And when it infiltrates in the surrounding brain, if you're too tight on your radiation, you're probably going to miss some disease, and then you're going to have a high risk of recurrence. And in fact, when coupled with conventional radiation, there has not been shown any benefit to the addition of stereotactic radiosurgery. Similarly, brachytherapy, where we actually put seeds in the area of the resection cavity, does not seem to show any benefit in terms of reducing the risk of recurrence. But those are older studies, and sometimes people are starting to kind of reconsider some of these options, especially since we have newer chemotherapies like temozolomide, which may do a better job in terms of controlling the disease.
James, can I just ask something? At this point too, we'd emphasize that if Optune's going to be an option, that's usually after radiation, as well as the fact that all his genomics aren't back yet, but there's a balance between waiting for all the genomic information versus getting on with treatment while you can still help. And then just the comments about, think about the PCP prophylaxis. Patients, as you know, with chemotherapy and radiation get a little immunosuppressed. So most people think they need to be protected with PCP prophylaxis, one of those antibiotics. And always, always, always try to reduce the dose of steroids to be as low as you possibly need, so you're not on them for a long time. Thanks.
Thank you. That's a great point.
I echo Dr. Forsythe. Yeah.
Yeah, so
I echo Dr. Forsythe's comments because, yeah, temozolomide, the steroids is something that sometimes the radiation oncologist actually is managing and helping to monitor along with the neuro-oncologist. And, we sometimes adjust the dose, but we always try to get them off as quickly as possible.
That's a great point. Thank you. So we have a few options, but for the most part, after a good recession in GBM, it's pretty standard therapy. So we'll go to the next slide. So this patient did what we kind of talked about is the standard 6 weeks of concurrent temozolomide, the chemotherapy with the radiation therapy. The next slide. So it gets a little interesting. About 3.5 weeks after starting the chemotherapy and the radiation therapy, the patient develops severe headaches. And so out of a total of 60 gray is just a way to quantify the radiation. After 38 gray out of 60 were administered, he developed these headaches. And so we performed an MRI. And so just wanted to get some thoughts. So Dr. Chow, so you in this situation, you as a radiation oncologist, would potentially be giving the radiation, thoughts on, a patient developing headaches at this time, seems to be getting worse instead of better. What do we do? What are you thinking about? And this is the type of thing that we may consider talking about in tumor board.
Absolutely. So, this is something that, we have to kind of think strongly about, whether or not we re-image the patient, whether or not we just continue on with the therapy as currently planned. Sometimes when patients develop severe headaches, we may at first get a CT scan just to make sure they haven't developed a hemorrhage, in which case, that may have to be dealt with more emergently. The patient is MGMT methylated, so the likelihood of developing things like pseudoprogression is higher. So we may be concerned that this patient may be developing something like pseudoprogression, and we may try to push forth with the radiation and chemotherapy as much as we can. We may use steroids to manage some of the headaches as well.
So we'll go to the next slide. That's a great point. I think there's multiple ways to manage, and just to kind of build on what Dr. Chow said, pseudoprogression is not tumor regrowth, but a side effect of radiation and the therapy being treated. So kind of like a scar tissue effect that can have the effect of a tumor in the brain, but not true tumor. And so this is the MRI that was performed about 3.5 weeks into the treatment. And you can see here where the tumor was before, and the after surgery picture, it was kind of more of an empty hole. And it's kind of filled up with this kind of patchy, white material. And this becomes very hard to tell whether it's a tumor that's grown back very quickly in about 3.5 weeks, or what Dr. Chow mentioned is pseudoprogression, the result of the treatments that we're giving. And so this is a very classic, type of picture that we have, and we sit in tumor board and we say, well, we're in the middle of our, chemotherapy and radiation therapy treatment. The patient already had surgery once and not very long ago, and what do we do? So I want to open up the discussion, starting with Dr. Forsythe, as a neuro-oncologist who's giving his chemotherapy at this time, what are your thoughts? This patient's gotten some swelling in the brain, he's got some headaches that can kind of be controlled with steroids. I just want to hear Dr. Forsythe's thoughts first.
Yeah, I mean, as you know, it's extremely difficult. He's, I think in the history is sort of youngish, at least by my view, and in great shape, and yet has this apparent possible growth on his MR, and pretty shortly into the treatment course. And then as you can see on the MR, or you can't really see on this view, but there's quite a bit of swelling there. He's having a lot more problems. So if he couldn't tolerate, sometimes you get a magical response and it can shrink by 5 days of high dose steroids or something, but you just don't want to keep him on it forever. So you might have to take that out if steroids aren't sufficient to control the symptoms. And I think as Dr. Chow mentioned, in the back of our minds, because he's methylated, MGMT promoter methylated, you wonder if this might be pseudoprogression. And I think just for the people listening, it sounds ridiculous that we can't really tell if a tumor is growing because the treatment isn't working, or maybe it looks like it's growing on an MR because it's working too well after all the experience we have. And we spent a lot of time discussing this with the neuroradiologists, neurosurgeons, radiation oncology, and you just can't tell a lot of the time. So if Dr. Liu and the patient agreed, we'd maybe think about surgery just to kind of figure this out and be positive about what was happening. But I welcome other ideas.
Yeah, Dr. Chow, do you have any opinions after looking at the MRI?
No, I completely agree. I mean, I think if the patient, we don't want to escalate the dexamethasone to extremely high levels. If the patient's not getting any benefit, then, we may have to debulk whatever that is in order to get some relief of the mass effect on the brain.
Sure. And then if we get on the next slide, please. So this just summarizes kind of the treatment options that we kind of talk about and discuss in the tumor board. Do we continue the chemotherapy and radiation therapy and just kind of keep going and see how effective it is? Do we adjust radiation therapy? Do we add or subtract chemotherapy? And also, again, like we talked about, do we do surgery? And for this particular patient, because of the concern of the swelling and the headaches, we didn't want the brain to be pushed on, because obviously the more and the longer the brain gets pushed on, the more there's potential for permanent damage. We took the patient to surgery. Next slide, please. And so we took the patient for surgery because we suspected there was recurrent tumor. And so we collected the pathology, and then we went back to tumor board, and we asked Dr. McCauley to take a look and see what he thought.
Next slide. Oh, more imaging.
More imaging. This is the tumor on the resected on the right. We took it all out, and then the slide will be coming up. Next slide, please.
So I guess, again, a kind of an overarching statement when we're dealing with gliomas, particularly high-grade or so-called malignant gliomas, we don't kid ourselves. In 2020, we still have very, very few, if any, cures. We know that when the surgeons attack the tumor a second time, there will be some tumor that they detect. Sometimes it's residual from the previous resection. Sometimes it's growth of that residual tumor or progression. We can't really tell the difference. Of course, when we've looked at the original specimen, the stuff that's left behind is the problem. The stuff that comes out, it's not going to do the patient any harm anymore. So at Moffitt, we're very keen on trying to advance the science and looking at ways that we can manipulate or attack the tumor in sophisticated ways, either surgically or with chemotherapy. In this case, we, as you can see, identified different areas of tumor. This was obviously done by the surgeons at the time of removal. And then we would register that in pathology and provide information on the different regions that were sampled. And we can see here with the labels, the various different regions all have residual or perhaps progressive tumor. It perhaps isn't quite as highly cellular and as highly mitotically active as the tumor was, the original tumor, but it certainly is residual glioblastoma. I think the next slide has additional samples. Next slide, please. Oh, okay, so we're just going to the diagnosis. So there's a lot of necrosis in the tissue, but there was definitely residual viable neoplasm. Okay, James?
Yep, thanks, Rob. So the answer that we wanted was, we wanted to take the tumor out, but the only way to know what it truly was, what was growing back, was a tumor that was growing back, or was it scar tissue? The pseudoprogression that we spoke about is to take it out and ask Dr. McCauley to look at it under a microscope. And so it looked like there was some tumor, definitely some tumor there, as we expected. This tumor was going to grow back, but it was a lot of scar tissue. And so shows that, it was primarily scar tissue, so the treatment may have been working well. It's just a pseudoprogression. So then we go to the next slide. And so the next slide, and we talk about what do we do next. We've taken the surgery again, and halfway through the planned treatment course, do we continue with chemotherapy? Do we adjust it? Do we continue with what we plan on doing? And so I'd like to hear Dr. Forsyth and then Dr. Chow talk about what they think the next steps should be.
So So I think that mostly this is a dead tumor, so it's kind of this unusual circumstance with the MGMT promoter methylated where maybe the treatment might have worked a little too well for him. So I think we'd be very encouraged to continue with the chemotherapy now that Dr. Liu has given his brain some space and some time, and probably continue the chemo and radiation, I would think, but I'd be interested in what Dr. Chow said. In the background, of course, we're still waiting for the genomics. Maybe there's something weird in there that we can either target or might explain this, phenomenon. And we always think about a clinical trial, which we didn't mention for him. I'm not sure why he didn't go on one in the first place, but you're not really usually eligible for a clinical trial in the middle of your treatment. And it's just a challenging situation to deal with, because it's like you can't judge a book by its cover, even the basis of the appearance hasn't helped. So I would continue with the treatment personally.
I agree with Dr. Forsyth. We would just continue on with the radiation. I think one of the things that we may have to consider as part of the radiation therapy, there has been some gap since we stopped the radiation, and do we add additional fractionation to try to overcome that gap? What happens is that there could be some repopulation of the disease even after the surgery, and because of that gap. So do we add another week in addition to what was already planned for the radiation therapy? I think that has to be considered.
Great. Next.
Dr. Liu, can I just ask an unusual, with your research on stem cells that you've been working on, does this help in any way? Like, if it's pseudoprogression, there's no stem cells, but if it's progression, there's stem cells, kind of? Is that possible to sort that out? I know that's from left field.
Yeah, I think it's hard to say. I think what Dr. Forsyth is asking is that, we think there's a subpopulation of the tumor cells that are responsible, that are more prone to kind of developing more tumors, have the potential of kind of regrowing tumors. And so are they responsible for this? It's hard to say, because a lot of times we don't do surgeries this close together. And so it's hard to get a very good handle on how much of one cell population is present or the other one. But that's certainly something that is a potential for why tumors continue to grow back, is that these cells, these stem cells, are kind of evading our therapy. So for this particular patient, after some discussion, we decided to continue on and finish the treatment that he was originally on. We'll go to the next slide, please. And so we completed the remaining of the 6 weeks, and he got the 22 gray after the 38 gray to make the 60 gray. And then we put him on our basic surveillance schedule, which is MRIs every 3 months. And so next slide, I'll show the MRI 3 months later. And so just to give you an idea, the MRI on the left is the one right after surgery, and the one on the right is the one after 3 months of finishing off the treatment. And so we can see, again, we see some kind of patchiness. The white is growing back in the cavity where the tumor is. And so there's a little concern about what that means. So we're back to the same issue. We took out the previous time when it kind of came back during the middle of the treatment and had a lot of necrosis, a lot of scar tissue. But it's kind of showing up again this time. The patient doesn't have any headaches. He's doing overall pretty well. And so next slide. And so we're back to talking about this at tumor board, and we're watching the MRI, and we're back to the same kind of potential paths that we can take. Do we continue to observe the patient with maintenance therapy, or do we continue where we add on new chemotherapy or new radiation therapy, or do we do surgery? So this is 3 months after we completed our treatment. So we sit in tumor board, and so I'd like to hear Dr. Forsyth and Dr. Chow's comments on what do we do about this particular MRI at this time?
Yeah, it's very frustrating that it's looks like it might have recurred so soon. I would assume there wasn't anything specific on the MRI that suggested it was pseudoprogression again or not. Again, a youngish person who's in great shape and has a favorable genomics in terms of the MGMT promoter methylation. This shouldn't be happening so quickly. We'd be kind of waiting in the background to see if there's anything on his detailed genetic testing that came out that might explain this. So there's a few options. One is to wait and watch and do nothing, which I don't think is the right thing to do, but certainly up to him. We could try to temporize with a short course of steroids or something, maybe Avastin if he was developing side effects, and Avastin's a whole other discussion because it sort of complicates the assessment. Probably the first thing is really, does he want to have, he doesn't want to have surgery, but would it be useful to have surgery again and figure out exactly what's going on? Is there a new protein in there that maybe there's a drug for, or some explanation for this behavior? And, is there a clinical trial? Is it time to, I don't know if he was treated with Optune or not, but that might have been started after the radiation, or he might have decided not to try that. So those are options. So it's a little unclear. I mean, we'd have to get together as a group and discuss it as we usually do. I don't know if you had any other ideas, or Dr. Chow.
Yeah, I always think that these imaging findings are tough. We try to tease out whether or not that's tumor recurrence versus pseudoprogression, and we sometimes get cerebral blood volume or perfusion, which assesses the amount of blood flow in that area to try to help make that determination. Long and short of it all, nothing has been proven useful in terms of determining pseudoprogression versus tumor recurrence. We might probably just follow, just to try to continue to see, is this truly pseudoprogression, and continue on with the temozolomide. Patient is 3 months out, then we're kind of getting out of the window in terms of what we would, consider pseudoprogression. So I think, we have to start to think about treatment options, as our next step. Again, if the patient is not on Optune, that could be considered, or starting a patient on a clinical trial.
Would you re-irradiate at this point if you were more confident about what it was, or is that too soon? Or
that's a good question. Yeah, it's a little on the soon side. Typically speaking, when we talk about re-irradiation, we don't like to initiate that until we at least have 6 months that has elapsed since prior radiation. Sometimes we even try to push it out even a little bit further. The sooner that we try to do more radiation, I think we run into issues of causing potential radiation necrosis. It's unclear that the radiation really helped out the first time around, if truly, in fact, they've recurred so quickly after the prior radiation. There are times that sometimes you have a new spot that has developed distally from the area that has been treated, in which case, in that situation, we may consider re-irradiation.
Right.
If it's local, like in this case, we probably wouldn't necessarily jump to radiation right away.
So that's a great point. So, a lot of potential options, and I think, what we ended up doing, next slide, please, it was, kind of decided a lot of times in this situation where we're not quite sure how to approach it and what the exact answer is. We like to monitor it, because, the less invasive therapies that we provide, I think the better if we're not quite sure. And so we continued our maintenance chemotherapy, and we did very frequent MRIs to kind of closely watch this. So every month we did MRIs, and then about 5 months afterwards, the MRI was performed, and on the next slide, please. As you can see here, on the right is about 5 months. On the left, the MRI was about 3 months after the completion of the treatment, and you can see continued development of this white patchy material in that tumor bed area. And so there's continued growth of this material, and so as Dr. Chow said, it's kind of coming out of the range of the pseudoprogression of this treatment effect. And so next slide. And so this is a time where we kind of talk about, what to do next. We weren't quite sure before. We kind of watched it and continued to grow. The patient starting having some headaches again. And so we bring this back to Tumor Board, and we talk to everybody and see what your thoughts are. And so just another tool that we use, as Dr. Chow mentioned, is that we use a perfusion study, which is an MRI that allows us to look at the blood flow through that area. And so we performed that. It's not a foolproof test, and actually showed that there was very low blood flow through that particular area. So with that information, although it's not foolproof, we bring it back to tumor board. So Dr. Forsythe, what are your thoughts?
Well, I think there's, again, a big tumor mass there, and if you and he were willing, that surgical resection might be useful, again, to look for targets. Of course, you can't reoperate forever, and nobody wants to do that. It's, as Dr. Chow said, it's a little late for pseudoprogression, getting out to 5 months or so, even without the hyperperfusion. So it's a bit, the comments are a bit similar to what I mentioned before. You know, we could, I don't think it's right to keep temporizing the steroids, and then if you get side effects, or if you give Avastin, it's just going to mask it and then make surgery impossible for 6 weeks or so. So I'd want to talk to him about, and you, about considering surgery rather than just continuing or switching chemotherapy or adding CCNU with Optune. It's difficult.
Sure. Dr. Chow, any considerations about radiation at this point? This patient's having a little bit of headaches. This mass is getting bigger. What are your thoughts on a radiation's role?
I think, you know, now that we're talking about beyond 6 months of, after the prior radiation, if I count correctly, I think that could be considered. But, you know, just as Dr. Forsythe mentioned, I think if we can do something from a surgical standpoint first to establish the diagnosis, that would be helpful. You know, it's still a little bit on the soon side to do repeat radiation. When we talk about repeat radiation, usually it's a more truncated course of radiation. Sometimes we try to strategize by doing pulse-reduced dose rate, where we actually purposely prolong the course of radiation, or each session of radiation, I should say, to slow down the delivery of radiation and potentially try to mitigate some of the long-term effects of repeat radiation. But, you know, given the mass effect in this particular patient, and, you know, the lack of perfusion, which is really confounding the diagnosis, I think surgery would be the next best approach.
And I don't think we want to just talk about a clinical trial just because there is mass effect and it looks like it's growing in a short period of time. So I really think that's appropriate right now, although we always think of that. I forgot to mention that.
That's a great point. So, you know, after discussing this patient in our tumor board, similar, you know, points were raised. I think the bottom line was that we felt that the mass was growing. It was causing, again, compression on the brain, which we don't want, causing headaches. And so we needed to have a better idea what was going on. And so we took the patient to surgery. Next slide, please. And you see here on the right side, the right picture, the left picture was before surgery, and the right side, the mass, the white part had been taken out. And so again, we asked Dr. McCauley back in tumor board to assess what was taken out and how much was actually tumor and how much was it maybe necrotic or non-tumor tissue. Next slide, please.
Thanks, James. So once again, you can see the various panels, and some of them are identified by the surgeon as being from a particular location. You can see that there are some areas, for instance, the top right panel, where there's very little tumor. The pink material is the intrinsic brain substance. It's the processes, the extensions of the cells that signal the neurons, and also some of the supporting cells. There's one large cell sort of near the bottom of that top right panel, which is most likely a neoplastic cell from the tumor. But the tumor is definitely back. You can see that the left two panels, the right occipital and the right brain tumor on the C panel. That's active tumor, that's growing well. And you can see the Ki-67, now that's an immunohistochemical stain. That means it's a technique where we try to identify particular molecules, usually proteins, that are in the tissue. And in this case, the Ki-67 molecule is a protein that signals that the tumor is proliferating or dividing, growing. And each one of those brown dots represents a nucleus which is or has recently divided. And a percentage there of 30% represents fairly brisk proliferation. So there's no doubt this is still active tumor. And I'll probably end by just saying, Dr. Forsythe has alluded several times to the interrogation of this tissue on a genetic basis. So my role as a pathologist, I act as a steward of the tissue, and I try to select appropriate tests to try to decipher the mysteries of the tumor. But there's a huge team of people behind me in some cases above me, particularly the personalized medicine group, which acts to interpret the sophisticated genetic testing that we get. Dr. Wacko and her team are extremely good at working out which targets may be present or may not be present in a particular tumor type. And so when we get sophisticated information like that, we depend on our colleagues to try to help us look for more targets. Next slide. So, oh, sorry, James, I'll give it back to you.
Of course. So we did confirm that thanks to Rob's help that there was tumor regrowth and a lot of tumor regrowth. And so we're back to, again, in tumor board, this patient's been taking the surgery 3 times in total now, gone through his standard course of radiation therapy, chemotherapy. And so back to our typical questions. Well, what's the next step? Do they include chemotherapy, radiation therapy, or clinical trials? And so for very briefly, so we can move on to the next case, Dr. Forsythe, Dr. Chow, what are your thoughts on chemotherapy, any options, and radiation therapy?
So I think we'd always advocate for a clinical trial, and we have several that are available that we'll talk about in the next session. Sort of off clinical trial treatment, I think Dr. Chow agrees would probably be reirradiation, I guess, with temozolomide because he's methylated, maybe followed by lomustine or CCNU, I would think. And
yeah, I definitely think that reirradiation could be reconsidered. One of the things that we always try to promote is clinical trials. I think it gives patients access to novel therapeutics. If we initiate radiation therapy without giving careful consideration of clinical trials, we can be shooting ourselves in the foot in terms of preventing patients from getting access to future clinical trials. So I think that always has to be thought about. So when in a situation like this, I certainly would encourage patients to, visit a center like Moffitt that has an established brain tumor center that has access to clinical trials, to see if there's anything available for that particular patient.
Yeah, that's a great point. So in this particular patient, there was a clinical trial for recurrent tumors that included a certain type of radiation therapy, and then also immune therapy as well. And so this patient actually went on a clinical trial later on. And so we'll move on to the next case quickly. Next slide, please. This is a 56-year-old male with a history of non-small cell lung cancer. He developed headaches, had some slurred speeching, and a right-sided facial droop. And he developed seizures. And so we'll go to the next slide. He presented to us, and then we did some imaging, and it showed, you can see on the left picture here, there's a big mass on the side of the brain there. But also in the other imaging on the right panel, you can see some other masses at the base of the brain. And so next slide, please. So it looks like from the interpretation of the imaging that he has potentially some metastatic brain tumors that are consistent with his history of lung cancer. Next slide, please. So this is a very typical patient that has multiple brain tumors, and so we're left to talking about the course of action in tumor board. What's the best course of treatment? And so surgery is certainly an option for brain tumors, and the kind of indications for surgery depending on the size of the tumor and whether the patient can tolerate surgery, and also other options such as radiation or chemotherapy. So very briefly, Dr. Forsythe, any chemotherapy options for lung cancer or brain metastasis?
well, there's many, but I guess with him, I'd be a little concerned. He's symptomatic and has that large tumor. It looks like his symptoms are related to that. So before, at the risk of frustrating you, we want to just talk to you about surgery, and then there's something in the back of his brain too, which can sometimes be a dangerous area. So I'd want to talk to you and see what, if anything, we should do about that first.
Dr. Chow, radiation, your thoughts on radiation for any or all of these lesions?
So when we think about radiation options, we divide that into doing something more comprehensive like whole brain radiation, which can be done with hippocampal sparing to try to spare the memory centers within the brain, versus doing something from a stereotactic radiosurgery standpoint. Given the limited number of spots, even despite having that big left frontal mass, certainly we can consider doing radiosurgery. I suspect this patient is, quite symptomatic from the left frontal mass. So in order to relieve that mass effect and pressure, surgery would be recommended. When surgery is done, radiation will have to either follow But one option is to actually do the radiation beforehand, or the radiosurgery beforehand, I should say, where we actually do the radiosurgery, try to sterilize the disease before doing the resection, and that may streamline the overall approach for this particular patient. Sometimes if we just do a radiosurgery approach, because of that size, we may want to consider just fractionating it or doing a staged approach where we would bring the patient back in a month's time and re-challenge that area with more radiosurgery. But overall, given the mass effect of that particular left frontal mass, I think probably the next best step is to consider surgery for this particular patient.
Sure, a couple of options. We actually decided on a kind of a hybrid option where we did surgery on the bigger lesion and radiation for the other ones. Next slide, please. And so you can see here the mass and the biggest lesion was resected. Next slide. And then so we took it to Dr. McCauley to verify the pathology.
Yeah, so this is a fairly straightforward case. It's a metastatic carcinoma. It's got some indication that it may have arisen from a neuroendocrine cell. Next slide, please. It was operated on the outside, and then we also looked at the tissue that Dr. Liu provided from the inside case. Similar features. Next slide, please. And so both showed a probable lung cancer with some neuroendocrine features. Okay, James?
Yep. So that's kind of highlights something we always do. We always obtain the outside pathology to make sure it they correlate and they make sense. The next slide, please. And so then we proceeded with radiation like we talked about for the other lesions, both to where the tumor was resected as well as the other lesions. Patient did very well for a while, but then developed some worsening speech problems again. Next slide, please. And so you can see here in the area of the resection, there's some, whitening kind of regrowth or potential regrowth versus scar tissue development, as well as the other places that were treated. Next slide. And so now we're back to kind of thinking about there's some potential regrowth of tumor or just scar tissue. It's a very difficult question to know what we did. And so for the sake of time, we talked about this in tumor board, and we have a couple of options. You can always go back and do more surgery, as we've shown in a different type of case to get tissue, or we can do more radiation, which is, also can cause more problems, or treat tumor, or chemotherapy, which there aren't a lot of great options for. And so next slide. And so we talked about it. We thought a lot of the previously treated samples tumors were scar tissue effect. And so we decided to leave those alone, continue to monitor them. The new lesions we treated with focused radiation. And the patient did well for a while, but then developed some increased headaches and had some more seizures. He developed the right previous lesion in the base of the brain that had radiation before, showed some enlargement. Next slide, please. So you can see here, this is the tumor site, and the previously radiated lesions are all kind of growing a little bit. And it's unclear whether it looks like real tumor or just radiation effect. Next slide, please. And you can see here at the base of the brain, this is on the picture on the far right, there's the lesion at the base of the brain is causing a lot of swelling, and the brain is being pushed a little bit. And so we're concerned that that one that's been previously treated with radiation may be really tumor recurrence and not just a scar tissue effect. And so we took that patient to surgery. We discussed it and took that patient to surgery for that particular lesion only because we're concerned that it's causing some symptoms. Next slide, please. And so again, imaging diagnosis, tumor recurrence in the lesion at the base of the brain, and the other ones were potentially scar tissue effect, which we discussed with our radiologist. Next slide, please. Next slide. So this is the after surgery slide in which we took out the tumor at the base of the brain. And so to see whether it was really tumor tissue or scar tissue, we asked Dr. McCauley to chime in again. Next slide, please.
Again, a fairly straightforward biopsy. Again, a diagnosis of probable lung cancer. And again, you can see that bottom right panel indicates that the tumor was actively growing, lots of mitotic figures and a high Ki-67 proliferation rate. So this is an aggressive tumor. Next slide.
So it kind of confirmed our thoughts when we discussed it that the tumor at the base of the brain was indeed true tumor occurrence, and that's why we went after it with surgery. But the other ones we thought were radiation necrosis or scar tissue effect. And so one of the things that we can do for the scar tissue effect is using a drug called Avastin. And Dr. Forsythe, maybe you can comment on medical treatments for scar tissue effect after radiation.
Yeah, it's a problem though. Radiation can, of course, it's extremely effective, but it can cause swelling and inflammation, which can be treated with short courses of steroids that have all the side effects of steroids, or the Avastin, which helps reduce the swelling in that way. It does have another beneficial effect. It can be quite effective and very, very effective in the short term and long term. The other thing it can do is let people develop, let people tolerate immunotherapy. So many people are usually getting immunotherapies for lung cancer sometimes, of which he might be a candidate as well. So it would be a way of sparing the immunosuppressive effects of steroids.
Sure. So we decided that, these other lesions were likely the scar tissue effect. So we placed this patient on this drug called Avastin. And there were a couple of new lesions in which we applied the focused radiation, the stereotactic radiosurgery for. Next slide, please. And just to give an idea that we continue to follow the patient in the imaging, on the very far left, you can see that the patchiness is a little less bright. And that's one of the things that can happen when you apply this Avastin therapy to scar tissue effect after radiation. And so it appeared to be working and the patient was getting some relief. So multiple things happening in the brain at the same time, some scar tissue effect, some tumor progression. I think this highlights, coming to a tumor board is saying, which one do we attack with what strategy? We might have to use different strategies at the same time and kind of space them out in accordance with what the best course would be. And that concludes our cases. Next slide. Thank you. We'll take any questions at this time.
Thank you all so much. Just as a reminder, again, if you do have questions, please type and submit it using the chat box at the bottom of your control panel and send any of your questions to the ABTA. So Dr. Liu, I'll address the questions to you and then you can let us know who the best person on the panel is to answer it. One of the questions we have here is about genetic testing. Is genetic testing for mutations such as IDH, EGFR, et cetera, is that available at most community hospitals as well, or is that only available at the larger teaching hospitals or research centers?
Yeah, I think that's a great question. I'll ask Dr. Forsythe and Dr. McCauley, who do a lot of the medical treatments and analyze and take care of that. Dr. Forsythe, would you like to comment on this?
So in theory, it's available in a lot of places, but it's really not. The issue is not just in ordering the test, and there's several platforms that are available, for example, Foundation or Caris or several others. It's really not so much about ordering it, but it's about what do you do with the results of the test, which I think is a huge advantage of a large cancer center like Cleveland Clinic or ourselves. As Dr. McCauley mentioned, we have a personalized medicine service to help us interpret the results. So sometimes you can see a gene that might be mutated, one of the melanoma genes, but it might be one of the subtypes of a melanoma gene that doesn't respond to the usual inhibitors. And unless you have that kind of expertise and knowledge, you're not going to know that, and you're going to wind up giving somebody a therapy that doesn't work. And
can I just add something, Peter?
I think like the class 3, right? The class 3 BRAF, for example.
So can I just add something, James?
Sure, of course. Yes, please.
One of the things that I think this question is implying is, would I be okay to go and have my surgery and have my workup at a place that perhaps isn't quite as experienced with brain tumors or other kinds of tumors? I think the short answer is yes, you'd be okay, but your best chance is to come to a cancer center where there's a lot of experience. And it's because of partly what you're seeing right now. We have these kinds of discussions, not just formally on a weekly basis at a tumor board, but pretty much ongoing. And all of you guys will be familiar with the emails you get from time to time from me regarding a particular case. I've seen it in review, and it may be a good candidate for this test or for that test, or I've asked for a test and I've got it back and here are the results. So as Peter suggests, it really is key who it is that's ordering the test, who's interpreting the test, and then what they do with that information.
I think there's so much information and data now that we need help as a team. Sometimes when we look at a genetic profile in a tumor, there's little hints that maybe there's something going on in a way that it might be heritable or something, or maybe somebody has a genetic predisposition to a breast cancer or something. And again, that's too much for me to understand or follow. So to properly evaluate that patient, we need the personalized medicine service and then our genomic team, our genome team, to see, is this actually a mutation that's important, so you have to worry about your kids, God forbid? Or is this something that just happens randomly and it doesn't mean anything? To amplify Rob's point, a comprehensive cancer center, Dr. McCauley is a molecular neuropathologist and board certified and has years of training. And there's a lot of pathologists that look at the brain tumors really aren't trained. They don't have subspecialty training where this is all he does for a living. Or even looking at MRI scans, you've seen us sort of discuss and argue back and forth. And we have 4 full-time neuroradiologists, and all they do is look at brain tumor scans. And they have, in a couple of cases, decades of experience, and we really need them when things are controversial or difficult to sort out. As I say, you only have one chance to get this right, so we really need to bias the way we do things to do the best job possible the first time.
Great, thank you. Now, we have a question from a patient here about who to contact at Moffitt if they're interested in having someone at Moffitt take a look at their case, their tumor, their history, and maybe get a second opinion or information on what they can do moving forward.
Yeah, I think you can start with our website, but the general number would be on there to call, and it would be very easy to get you connected with our neuro-oncology group and get all the information and have you set up. The website is moffitt.org, moffitt.org.
Perfect, thank you. Another question we have here is about the Optune device as a treatment. How widely is Optune used, and is this becoming part of standard of care? Yeah, so the Optune device has actually been approved as an adjuvant therapy to be used after the surgery and the initial chemo and radiation. I think it's the use is still dependent on the provider as well as the patient discussion. One of the things about the Optune is, it's certainly a commitment to wear the device, and some people, like it, some people don't like it, and I think it's something that has been shown to be helpful in the previous studies that have been done, and more studies being done to continue to learn more about it. And so I think the widespread use is really dependent on where it is and the discussion that's happening between the patient and the commitment that the patient wants to make to kind of using the device on a regular basis. Dr. Forsythe, anything to add?
I think there's pretty strong data that's useful, and it's in the NCCN guidelines. There's a large randomized trial done by Roger Stoop with long-term follow-up. And it really comes down to an individual patient decision after radiation to think about it.
Thank you. Another question we have is, are there any targeted treatments for glioblastoma?
Dr. Forsythe?
So it's a bit unusual for targeted treatments. The short answer is it's uncommon, maybe 5 or 10% of the time will be a targeted treatment. It's frustrating for everybody. In the first, not particularly patients and families, in the first patient that Dr. Liu talked about, they did have one of these proteins called EGFR sitting on the surface of the cell that people have known about for decades, and I think Webb Cavaney discovered this So there is a target that's sitting on the surface of a tumor cell, and it would seem very easy to get a drug there to interfere with that function. But so far, the clinical trials in actually getting this done haven't been successful. So maybe it's a bit like COVID-19, where you know it's there and it seems very simple to develop a vaccine. Why aren't we getting on with it? But it's resisted treatment so far. The 5 or 10% of the time, there's a lung cancer protein for which there's new drugs or new neurologic mutations or genetic modifications for which there's new drugs, but that's maybe 5% of the time. You know, if you're in that 5%, it's a big deal because people can respond dramatically and quickly. Dr. McCauley mentioned another target in that first patient that we talked about, or some patients, although it's uncommon with grade 4 tumors, have an IDH1 mutation, so there's a huge effort in many clinical trials underway to develop new drugs to target this mutant IDH1 protein, but we're waiting for the results of those. So nothing approved in a targeted therapy yet for most brain tumor patients. Again, to talk about personalized medicine that Rob mentioned, when we do encounter a patient like this, the personalized medicine service helps us to get drugs approved very quickly. You know, sometimes in a few days. Sort of already has a template written when it's first refused by insurance. So one of the last patients that Rob and I spent a lot of time talking about, he was able to get his sort of melanoma drug, because he had an unusual GBM, to his house before we could get the temozolomide approved.
Thank you, Dr. Forsythe. Another question we have goes back to the Optune device again. Is Optune available to use for a patient who might have a secondary brain tumor or a brain metastasis?
Dr. Forsythe, do you have a comment on that?
I don't know that it's approved yet, and I haven't actually tried that, but that's a great question. I'm sure that Optune has some clinical trials looking at brain mets, and the nice thing about the Optune therapy is that its side effects are fairly minimal, so if it is going to have an effect, it would be interesting to know. We're waiting for some clinical trials to be completed before we know what the data are. And again, there's very little in the way of side effects, so it would be something that might be useful to add.
Yeah, I believe there are clinical trials involved. It's not, it hasn't been approved to be, widely used yet, like it's for glioblastoma, but there are clinical trials currently underway.
Thank you. And are there any limits to how many surgeries a patient can have?
So the short answer is no. You can do surgery as many times as necessary or as you want to. The limitations of surgery really are the brain itself. Surgery, obviously, the biggest thing that we fight is damaging normal brain or parts of the brain that may, prevent someone from functioning at the desired level. And as the tumor continues to spread, depending on the type of tumor, is it in an area where it's amenable to surgery? As it gets further and further away from maybe a place that it started out where it was more amenable to surgery. Wound healing, obviously, is challenging. Every time you go in the same wound, again and again, the scar tissue effect kind of builds, and it could potentially be a bigger and bigger problem. Every time you have another surgery, the wound healing is more at risk, but a lot of times it's not a problem. And so technically there's not a limitation in the sense that you just can't do it. It's more about the situation, where the tumor is, the effect of surgery on that part of the brain that's affecting at that time, and also the potential for wound healing problems.
Thank you so much. And that is actually all the time that we have for questions today. I'll go ahead and turn it back to Emily.
Great, thank you so much. I just wanted to say thank you so much for each of you for that panel and for this informative presentation, and for all of those that shared their questions, and we definitely hope that this will give you a glimpse into what it's like when each of the different disciplines come together in order to come up with the best treatment and outcome for each of you. We will now begin our final session, which is titled Medical Billing and Financial Resources. This session will include medical billing and financial resource expert panelists who will provide an overview of how to maintain financial wellness during a brain tumor treatment. The panelists will address the following topics. Next slide. Billing for clinical trials, navigating insurance, hospital bills and financial support, prescription medication, and physician billing overview. Once each panelist has shared, we will open it up for attendees to ask questions. Serving as our panel moderator today is Andy Talford, Director of Patient Financial Services at Moffitt Cancer Center. Andy, feel free to say a few words, and then we will open it up to each of the panelists to start the presentations.
Gotcha. Thank you very much, Emily. I appreciate the introduction. Thank you all also for sharing. I certainly learned a lot from your discussion. But I think what we know is that the financial journey for cancer patients can add a lot of stress. And I think we hope in this little section is to bring just some knowledge and understanding to the financial portion. So maybe we can make that a little less stressful with some of this information. So without further ado, I would like to introduce Christy Moffitt, who is our Senior Director of Clinical Research and who is going to be discussing billing for clinical trials. Christy.
Hi, everybody. Can you all hear me okay? Okay. All right. So I'm Christy Moffitt. I work at the Moffitt Cancer Center, and just to clarify, there is no relation. If you notice, the two names are spelled differently. I'm the Senior Director for Clinical Research there, and so I kind of oversee all of the clinical trials that are going on at Moffitt. So we have the execution, so getting them open to the closure and the recording of the data for all the clinical trials. Next slide. So disclosures, if you can go back, I'm sorry. I have no financial or support disclosures, but one thing that I do want to point out is that I would not consider myself an expert in billing overall. My expertise is in clinical trials, so I'm trying to focus on just the billing portion that is affected by clinical trials here. It takes a village to do clinical trials billing, and all of the people who will be presenting after me play a vital role in the whole structure for clinical trials billing. Next slide. So I just want to start off by acknowledging the team at Moffitt that we have for clinical research. There are approximately 300 people who make up the team, and you can see here a picture of some of those who were on site on that particular day, but it ranges from so many different positions, from coordinators to financial people to lab people, and then all the other departments within the Moffitt Cancer Center who support that. And so I just want to acknowledge the team that makes this all possible. Next. So for my talk today, what I'm going to be going through is how is clinical trials billing determined? How much will it cost me to participate in a clinical trial, including a clinical trial billing grid? So I'll be explaining a little bit about that. And then I'll be going through some myths and misunderstandings that I have seen throughout my career in clinical research to kind of explain some of those things that come up from time to time. I do want to start off by letting you know that this is a pretty dry topic, so I tried to spice up the slides in any way I could with pictures and everything, and I just really failed at being able to really spice it up. It's something that is absolutely necessary for billing, but it's not something that presenting it, you can find a good way to spin on this to make it really fun. So I apologize for that. This all started back in 2000, where we are in current state clinical trials billing these days. So the president had issued an executive memorandum saying that Medicare should pay for routine patient care costs and costs due to the medical complications associated with participation in clinical trials. This is to assure that we're advancing science, that we are able to find new cures, and have the ability for people to be able to participate in clinical trials. So that resulted in the clinical trial policy for national coverage determination. So that came out just a little bit later in 2000 and was updated in 2007. And that was a policy that was set for the Center for Medicare and Medicaid Services, but it's ended up being used by the insurance industry in general. And so they kind of followed the same rules that they set for CMS in order to do that. Some states have also come up with their own laws in regards to requiring insurance companies to pay for services that I'll be going through in this presentation for patients who are participating in clinical trials. Next slide. So it starts with a coverage analysis. And what I mean by that, it's a review of the items that are on a clinical trial to determine how they're going to be billed. Are they going to be billed as research costs? So in that purpose, it's things that are done solely for the purpose of research and they should be billed to the study. Or are they routine costs, things that are sometimes called standard of care, you may hear, or conventional care. And those items are billed to the participant or their insurance. And I'm going to go through that in a little bit more detail on the next slide. Next slide. So the routine costs in clinical trials are basically the services or items that are typically provided if you were not on a clinical trial. So again, that standard of care or the conventional care. When you get down into some of the details and the laws that are out there, so it identifies items that are required solely for the provision of the investigational item or service or administration. And I highlighted administration because I'm going to be going through that a little bit more in the myths and misunderstandings. You look at the terminology that's here and it's very much governmental speak. And so it's kind of hard to understand from anyone else's standpoint of what did the government mean in these laws. So it also covers the monitoring of effects of the item or service or prevention of complications, so side effects that may occur for a participant on a clinical trial, or to prevent side effects that may occur. And then also the covering the diagnosis and treatment of complications. So again, that's getting to the side effects also, but they wanted to outline that very clearly that, you know, some of those things can happen and they are able to be covered by Medicare or Medicaid. Next slide. So how much will it cost me to participate in a clinical trial? That is a very loaded question. So it's very different for everyone. And so I'll go through a little bit of the details of what may make it easier to understand how to find that out, how to determine that for you. So the first step is starting with the informed consent form. So that's the big packet that you may get that goes through all of the information about the clinical trial. That is key. It's what you use to determine if this trial is right for you. And it goes through lots of different things about the details of the trial, but one thing that is important for this topic is the cost section. So sometimes it has very generic language that may say the things that were on the prior slide about that the study will cover the research costs, but the routine care or routine costs will be covered by the participant or their insurance. And sometimes it's very detailed. It just depends on the trial. It depends on the healthcare institution of how they set that up. Actually, the institutional review board that reviews those informed consents for the ethical purposes. And so that can vary from consent form to study to study. So my next step is that you should reach out and talk to somebody in the financial area, whether that be a financial counselor or whatever that role may be at the healthcare institution that you're attending. So like I said, every insurance plan is different. So this is why it gets pretty complicated. Everybody has different copays, different deductibles that would apply. Some people have already met their deductibles, some people have not. And so outlining how much participation on a clinical trial may cost you is very person specific. And so reaching out to somebody to go through that with you and look at your insurance plan, where you fall and your deductibles, your copays and things of that nature would be important, because that's going to apply to all of those things that are on a trial that are considered routine costs, those things that would happen whether you were on the trial or not. So that person can review the billing grid with you to help you understand the study. And I'm going to go through a little bit about that here on the next slide. So the billing grid really just outlines those things that I went through, the routine costs and what is research costs. So what is paid by you or your insurance and what is paid by the research study. So the billing team references this, this billing grid that is done through the coverage analysis to be able to know that they are billing appropriately. So they're not billing you for things that should be billed to the study or vice versa. So the financial counselor will use this billing grid in order to estimate the costs when they're, if you were to request an estimation for those costs. So I just mocked up a very basic billing grid here. They do get very complicated, and so sitting down with a financial counselor to understand that is often something that you may choose to do to really get into the details and understand it in more breadth. But here you'll notice that anything that is paid by Medicare or an insurance is noted with an M, and anything that is covered by the sponsor or the research study is covered with is noted with an S. So you can tell that there are a couple of drugs on this study. There's an infusion that has to happen for the for one or both of the drugs. And you've got some physical exams, some labs, that CBC is a lab, and then the venipuncture is something that happens in order to draw the labs for the study. So you can note that throughout the life of the study, it varies. And so that's all based on the coverage analysis that's done. And the coverage analysis goes back to the standard billing practices across the nation for how the different diseases, diagnoses and treatments are billed across the country nationally. But then locally, each area has its own local coverage determination that they have that each area reviews and abides by. So we have to go through the process in that coverage analysis to assess what the national coverage determination is and what the local coverage determination is in order to develop which one, the M or the S, that would go in here. And so it is something that is required for studies to be able to go through and assess, and we have to keep that consistent for all patients. So it needs to be fair across the board to everyone, so everyone is being billed the same way. Next slide. So getting into some of the myths and misunderstandings, one thing that I've heard a lot in the past is that everything on a clinical trial is free. So in cancer clinical trials, that is rarely true. And I note that because of the national coverage decision, so that NCD that I talked about at the beginning, and the fact that most cancer trials include more than just the research drug. So they're including standard of care or routine care, you know, what you would get as a chemotherapy anyway, and then they add another drug to that to do for the research study. So it's the combination therapies that happen in cancer trials most of the time that mean that not everything that is written into the clinical trial would be free. So that's where your routine costs come in, where things that you would be getting normally. And another one is everything everything to do with research drug is free. And this goes back to where I highlighted that word administration that is very much governmental speak. That word administration is really meant to say, how are we giving the research drug or device? So is it an infusion? Is it an injection? Is it in pill form? And so some of those times are what we see that people question, because they say, well, that's a research drug, so that infusion should be covered by my insurance. But actually in the national coverage decision, they have determined that giving the administration of that drug is billable to Medicare, Medicaid, or an insurance company. The drug has to be covered by the study, but the actual delivery of the drug can be billed to Medicare, Medicaid, or insurance. If routine care is a pill, but the research drug is an infusion, then I won't be billed for the infusion. That's where Medicare, Medicaid does not discern what types of delivery that is. So even if the standard of care is a pill, but you're getting an infusion, the infusion is what would be billed to you or your insurance. And as you're all, I'm sure, aware, infusions are much more expensive than a pill dispensing. So that is something to be aware of, and that's something a financial counselor can go through with you to identify that those things that would be billed to you or your insurance, and that it might impact your co-pays, deductibles, and things of that nature. So what if my insurance company says that clinical trials are not covered? Many times people do reach out to their insurance company. They want that reassurance that the insurance company is going to cover the routine costs for a study. But when they call, they say, are you going to pay for my clinical trial? And the insurance company is going to say no, and they're technically correct in saying no, because they're not responsible for the things that are research related and should be paid for the study. And so when they say no, they're saying no, they're not going to cover the things that I noted that were sponsor paid or for the research study. And that is correct. They're not obligated to pay those things. And so they only have to pay what's allowable or cover what is allowable for clinical trial billing, and they do not have to cover those things. So it's one of those things that when you speak to your insurance company, you have to be careful of how you frame the question, because the answer may not be exactly what you were intending. And so we've had quite a few patients that come back and say, my insurance company said that they won't cover it. But in fact, they will, based on what the coverage determination is, and also the state laws that I referred to that say that they must pay in many states too. So, so next slide. So this is just my disclaimer slide, and I think that is the end of my time, and so I'll hand it back to Andy.
Great, thank you, Christy. Let me introduce Ms. Viviana Balan. She is our Director of Financial Clearance Unit, and she's going to speak about navigating insurance. Go ahead, Viviana.
Thank you. Can you hear me fine? Okay. It's a pleasure being here today. As Andy mentioned, I'm representing the Financial Clearance Unit. We are a centralized department that facilitates the registration process of new patients, and we're also responsible for obtaining insurance approvals for all types of services across the organization on behalf of our patients. Part of our responsibilities during the registration and at any point during treatment is to make sure that patients' insurance is in network with Moffitt. This to avoid unexpected financial burden. We also inform our patients about their benefits, their maximum out-of-pocket, which is the amount that needs to be met before the insurance pays at 100%. If a patient is going to receive treatment, most likely they're going to use the entire out-of-pocket. In our market, the average out-of-pocket now is $6,000 a year. During the verification process, we also identify uninsured and underinsured patients who could benefit from Medicaid or from our financial assistance program. For new patients, the financial screening is performed during the registration call to expedite the process. Authorizations. So how does the process look like? As soon as a provider places an order and the service is scheduled, my department is notified and the authorization process starts. What we do is send all the clinical information to the insurance company that supports the need for the test. Depending of the type of service, insurance companies could take between 3 or 10 business days to process the cases. Some services are approved with no issues, but other services are not. And some insurance companies are harder to work with than others. If we received a denial before service, we communicate the information to the ordering physician and the patient, and we all find a solution together. If our patients do not hear from us, nothing to worry. That means that all the services have been approved. Insurance information. It is very important for our patients to communicate any insurance changes promptly. This will avoid any delays securing the authorizations. This information can be communicated in many ways. When when the patients come for their appointments at time of check-in, or when the patients, they can call Moffitt hotline, or they can utilize the patient portal. It's very important as well to, when selecting a new insurance, enrollment period, Medicare Advantage, or Medicaid HMOs, to choose a product that it is in network with Moffitt. We do have financial navigators within the department who are available to assist patients with any questions related to insurance or authorizations. Another service that we help our patients with within the financial clearance unit is the copay assistance. Next slide, please. Thank you. So drug manufacturers, they assign resources in their budget to help patients for the use of the drugs. For this, they utilize foundations, copay assistance plans, or free drugs. Once the patients are scheduled for a chemotherapy regimen, we are notified. The financial clearance unit is notified, and we reach out directly to the patients to explain how the process works, and we enroll them in the programs that are available. If a patient is enrolled in a copay assistance plan, the patient's financial responsibility for the drug is billed to the charitable arm of the manufacturer. What it does is alleviate the financial burden for the patient. Next slide, please. This is an example. Anna has an employer-based insurance, and the out-of-pocket is $2,500. So she will be responsible for $2,500 before the insurance pays 100%. Dr. T orders carboplatin, which will cost her $200 per dose, and is going to receive 10 doses. After the insurance pays the claim, she's going to be responsible for $2,000. But this amount is billed to the manufacturer's charity copay assistance program. Then the $2,000 are paid to Moffitt by the third party. So at the point, patient is going to have only a $500 remaining to meet the insurance out of pocket for the cost of the year. Next slide. Thank you so much. I appreciate that.
All right, thank you, Viviana. I appreciate that. And my hope is, with my discussion, is that we can talk about the portion of the bill that most people are concerned about, and that is the one that comes to you in the mail and says, this is how much you owe. So there's been a couple of terms that we've talked about through the last bit of discussion, and I would like to kind of maybe define them a little bit and help you understand what they all mean. Also talk about financial assistance that most facilities have, and talk about Medicaid at the very end in just a little bit. So we can go to the next slide, please. So there's a disclosure form I think we've all seen. So just a little bit of terms here as we talk about, you know, how it works that you end up getting a bill for your portion of your healthcare service. These, by the way, are just general terms that apply differently to all plans. And I think you heard Viviana and even Christy before me talk about your insurance plan is differentiated from a lot of others because while every plan may have a deductible, yours is probably different than everyone else. So we usually ask two things of patients when they come in, and I think this helps the journey. And as Viviana mentioned, most hospitals do have a financial unit who would be very happy to help walk through your particular insurance with you and kind of take some of these generic terms and put them a little more in focus. The other thing that you can always do is call your insurer, and they will help you kind of walk through some of this as it applies particularly to you because every payer is different. But just in a general sense of the word, what my team does is we send a bill to the insurance company, and that insurance company sends us a piece of information back, and it has a couple things on it. And the first one is it tells us how much they're going to pay us for the service, and then it tells us how much we should bill you and how much you should pay. Your insurer is 100% in charge of telling us how much you owe. And we take that remittance back from the insurer and we bill you directly based on what they tell us. Now there's a couple of terms on there that I think are pretty helpful, and you might see them if you get an EOB from your insurance company, and you might be looking at it going, what in the world do these terms mean? The first one you'll get on there is called an allowable amount. It might also be called an eligible expense, a payment allowance, negotiated rate. There's a couple different terms for it, but most of them will have it on there. Basically, how insurance works is you probably are aware that in hospitals have what's called a CDM, which is a charge master, and we bill your insurance company a certain amount of money attached to charges. Okay, but what happens behind the scenes is this. Every insurer has a rate that they have negotiated with the hospital that really is the amount that you'll pay. Billed charges only really have any impact on those folks who are truly just self-pay. Everyone else is going to be paying from what the negotiated rate or the eligible amount is from their insurance company contract. So just to kind of say, okay, what happened there? That is the rate that we have agreed to take for your service from your insurance company. And every insurance company can be different. So that adds a little level of confusion to it, but they all can be. So the next thing that sort of applies to you, after we've determined what the allowable amount is your deductible. Everyone has one, but almost everyone is different. And so it's one of those things that you sort of have to understand what your particular deductible is. And like Viviana was talking about, how much of it you have already met, because that will depend on how much we're going to bill you for. If you want to go to the next slide, please. After the deductible, there's this other thing that's called coinsurance. So what happens with coinsurance is it's almost always a percentage. And what happens is coinsurance applies after you have paid your deductible. So the first thing you do is you will pay your deductible before your insurance company pays anything on your bill. They will go ahead and bill that to you. So once you have paid that deductible, then the insurance company will start to pay some portion of your bill. It's very similar to auto insurance and some of the other insurances that are out there. You get that deductible before the insurer pays anything. Once the insurer starts to pay, they don't generally pay it at 100%. They pay at some percentage. Maybe it's 90%, maybe it's 80%, and that remaining balance is billed to you in what's called a coinsurance. Now, every insurance policy also has something that Viviana mentioned earlier, and that's an out-of-pocket masks. And what that means is you will pay deductible and coinsurance until you reach a certain dollar figure, and then you will not have to pay any more. The insurer will pay 100% after that point. So all of those numbers are very good for patients to know, because they really do apply to what you are going to end up owing on the back end for your insurance. So what I did here was just sort of throw in a little kind of an example. So here it is. Patient X has a surgery at Memorial Hospital. Okay, we at Memorial Hospital sent a bill for $10,000. Okay, patient X has Blue Cross Blue Shield, let's just say, and the allowable amount for that surgery is $5,000. Okay, now your first question is going to be, what happens to that other $5,000 that's different from that number? Okay, that is what's called the contractual amount on your EOB, and basically what the hospital does is we adjust it off. Okay, so your bill now goes down to $5,000, and we start that process from there. So then what the insurer will tell us is, okay, you have to write off $5,000 of that $10,000 bill. So now you owe $5,000. The patient has a deductible of $3,000, and we are going to pay $2,000. So the insurer tells us all this. We say, okay, great. We write off $5,000. We take $2,000 from Blue Cross Blue Shield, and we bill you for $3,000. So that's kind of how the negotiation goes with your payer. Now, those are pretty round numbers. As you know, they can be percentages. And I didn't include coinsurance on this either, just to sort of try to keep it simple. But that is just a general overview of how we arrive at the number that you need to pay out of pocket. Basically, it depends on what your plan benefit is, and then how much of that plan benefit you have already paid. And like I said, we take 100% of the information from your payer. Okay, they tell us exactly how much to bill you, and exactly how much we should be billed. So that's just for information's sake. Okay, next. So this is a conversation about what happens when you get that bill for $3,000 in the mail. Maybe you can write a check for $3,000. Maybe you can't. A lot of people cannot, especially in the world we live in today with COVID. And we find this a lot too with those who are in oncology care, because it's a life-changing event a lot of the time. And so we really do at Moffitt try to give some leeway and some assistance to patients, because we know their life has changed. So all hospitals will give you some length of time to pay something on a payment plan. They all do it, but they all are different. So if you are interested in a payment plan, you can contact the hospital financial folks before you even go on, and they will tell you, here is our policy about payment plans. So there is a, also, just to mention, a lot of them will have them on their websites as well. So if you are shopping at a hospital, you can go out there and see, okay, what is this payer or this provider going to do as far as the payment plan goes? Just something that is new that has come up like in the last 2 or 3 years, and that is a lot of hospitals will use external vendors to do some of their payment plans. This is largely a financial piece, because we have all realized that patients need a lot longer periods of time than maybe they used to pay plans off. And so what we have had to do just to sort of maintain our cost a little bit is have some help from vendors out there. Just a note, because most people may or may not be aware of this, those external vendors can charge you interest. The interest will be noted on their websites most of the time, and you can even call them before you even have a bill and say, tell me, how much interest you're going to charge me on this. So you will bump into these two vendors a lot if you're out there and you're looking for an extended period of payment plan. And that's normally where you hit a vendor, by the way. If you have a short payment plan, like let's say under 6 months, 90 days to 6 months, if you can pay it off in that period of time, most of the time the hospitals will let you do that. If you're going a year, 2 years, 3 years, 4 years, 5 years, most of the time it'll go to a vendor. And these are very common vendors out there. Care Credit. In fact, I went to the dentist a couple weeks ago, and right there at the at the patient access place was a Care Credit application. So you will see those guys a lot. And Access One is another one that's pretty common. So next slide, please. So just at Moffitt, here is our policy. We do make payment plans in-house for 90 days. So we will let you make those payments. If you go longer than 90 days, we use a vendor called Access One. And plans that can be paid off in a year through Access One are interest-free. So you do get 12 months to pay it. Plans that go beyond that will bear some interest. Just because, to be honest with you, there's a cost that we incur in sending statements every month and sort of just managing the rotating nature of the payment. The great thing that we have, and what sort of led us to Access One, is the length of time that they will allow patients to pay. We have patients who have fairly high out-of-pocket, and they were really struggling in paying them off in 2 and 3 years even. So Access One actually allows up to 10 years to pay off that deductible co-insurance out-of-pocket max. So we felt like that was right for the patients at Moffitt, but like I said, you will need to contact the particular provider you're going to because they all differ. So next. So financial assistance policies, and I do not really want to kind of explain these in great detail because, to be perfectly honest with you, they are very different from facility to facility. But I will say this, most of them are fairly regulated by the government, whether that be the state government of Florida or even the federal government through the Internal Revenue Service. So if a insurance, or if a provider rather, a hospital has listed out, these are the things that you need to have to apply for financial assistance with us, they don't generally bend on them because they are highly subject to audit by the federal government, and they're very highly regulated. But almost all of the financial assistance plans out there follow some very similar processes. And the first one is this, they almost all grant financial assistance or don't grant it based on what's called FPL. An FPL is a number that is designed by the U.S. Department of Health and Human Service. You can actually go out to their website, the U.S. Department of Health and Human Service, and you could find out what your FPL percentage is. Basically, two things play into it. The first one is how many people are in your household, and the second one is how much money, how much income you have. And so that then comes up with a percentage that is a federal poverty guideline, and that is almost always what facilities will use to grant or not grant financial assistance. Just to note, almost all financial assistance policies have some form of exclusion. By the way, and I did not mention this, it is actually the law that facilities have to post their financial assistance criteria on their website and make it readily available to you. So if you go out to any website at any facility, you will see a financial assistance link, and it will basically be a link to their policy because we have to do that by law. And it should explain what their ruling is around FPL, and it should explain what they're excluding. And the other one should also explain what they call income. There is some variation between what is going to be income or not income. You could almost expect to have to bring pay stubs, W-2s, those sorts of things. Where the hospitals may differ is with assets, whether or not certain assets are counted, like a 401k or a 401(3), those types of things. So they are differentiated place by place. Next slide. So our financial assistance policy is on our website, and there is our website link. You can call our website, or our business office rather, at 745-8422, and they will mail you a copy. If you'd like it, you can drop by any of our business offices at Magnolia or at McKinley, and they will be more than happy to give you a copy and an application so that if you care to apply. At Moffitt, we do exclude certain types of services, and those are prophylactic surgeries. Genetic counseling in a screening capacity is excluded. CAR-T, ICE-T therapy is excluded. Patients with out-of-network coverage and patients who are not residents of the state of Florida are sort of excluded from ours. So next slide, please. And so here is our policy. If you come and apply to Moffitt for financial assistance, if you are at or below 200% of the federal poverty limit, we will offer you 100% charity at Moffitt Cancer Center. If you are between 200 and 400 FPL, we have a tiered charity program, which gives you a 65% discount on your bill. So that's how we apply those particular numbers. They can be different from provider to provider. So next, please. Okay, so one last thing, and that is Medicaid. We do have folks in-house who do assist in screening for Medicaid. And I work in conjunction with Viviana's department when patients come to us to screen them to see if they are possibly Medicaid eligible. And if they are, we actually will assist them to go ahead and apply for Medicaid in Florida and actually do some of the bill tracking and some of the other stuff that Medicaid requires of patients. So we do assist. And really, to be honest with you, most facilities will do this. So if you come there, they will pre-screen you to see if you are potentially Medicaid eligible. If you have mentioned to them you're having difficulty paying, and then we'll help you kind of navigate through that process of Medicaid. So hopefully all that was helpful. I know I ran through it in a very short amount of time, but hopefully it was helpful from an education point of view. So thank you. Okay, I think the next person who is Lauren Risso, who is the pharmacy manager at Publix, and we have a Publix pharmacy inside of Moffitt. And so Lauren, take it away.
Hi, thank you. I'm glad to be here. Hoping everybody's having a good Saturday. So as mentioned, I'm a pharmacy manager at the Publix pharmacy inside of Moffitt Cancer Center. We serve the outpatient population. So as you're headed home, usually when you think of your pharmacist, you're asking about drug interactions or how to take it. But today we're actually going to talk about how to navigate the financials on that. It's not always straightforward. So it's best to kind of seek the help of either your pharmacist. We actually have 3 resource specialists on site just to help navigate that, or even case managers can be very helpful. Next slide, please. So as a disclosure, I do work for Publix. Okay, next. So this diagram here basically represents your 3 main areas of coverage. You can see you have insurance, you have manufacturer programs, and foundations or charities. These can all be billed independently, or some of them may be combined. You might be able to combine your insurance with copay cards or with foundations. So again, it's very beneficial to have somebody help you navigate just exactly how to bill each prescription. So we'll go ahead and break these down a little bit. Next slide, please. The first one to talk about is commercial insurance or Medicaid. They're pretty similar. As quickly as we can enter the prescription into our computer, we'll have an answer. Is it going to be paid, or is it going to require additional information? So with both of these plans, one of the first things we talk about a lot is prior authorization, or PA is the pharmacy lingo. So if you hear this, the insurance company just wants a little bit of additional information for why that medication is necessary. It's usually either because it's expensive or because it may be being used for something the FDA hasn't approved it for. And that you'll usually have an answer back within 24 to 72 hours. If you are denied, it's not the end. You may be able to appeal it, which could take anywhere from 24 hours to 30 days. Medicaid has a unique aspect called share of cost. So sometimes you have to, not every person on Medicaid has this, but sometimes you have to hit your share of cost for that month before your Medicaid will kick in. So that can cause delays sometimes, but Moffitt does have special programs for that as well. I could probably do a whole presentation on Medicaid, but again, just seek assistance if you need it, if you're eligible for that. And then commercial insurance sometimes has preferred pharmacies. So this could simply just mean a price difference between which pharmacy you go to, which is usually pretty unusual. For the most part, your copay will be the same, unless your pharmacy has a complete restriction. Some, maybe for example, Remark, you have to go to CVS and different things like that. They may, if it's a specialty medication, it may require it to go to a specialty pharmacy, which could be in a completely different state. So I would expect delays with these kind of preferred pharmacies as well. There may be a transfer time. Some of these specialty pharmacies, you can sit on the phone for an hour just before they even get the prescription to start working on it. State laws differ, so if it is going out of state, it may be received by a pharmacy that can't accept the prescription, and they actually have to re-get the whole prescription directly from the prescriber. And then, of course, shipping time may come into play, or that pharmacy may have to begin that prior authorization process themselves. What we try to do, because we know there's a lot going on, we will actually, even if we get a rejection that we can't fill it, we'll get that prior authorization at our pharmacy before we send it out. So if you are at Moffitt, it is helpful to bring your prescriptions to us so we can start that process. That's a service that may not be offered at outside pharmacies. Next slide, please. The next, you may have Medicare Part D. You're eligible for this at age 65. This is the A and B portion is for your hospital, but Part D is your prescription drug plan. Some people have Part C, or what they call an Advantage plan, and that would be a combination of all three, your A, B, and D. And you're going to see the very similar delays to that of which we saw for commercial insurance. One thing you can do every year is you can go on to Medicare.gov and you can put in what medications you're currently taking, and then it'll pop up the right plan for you, because there are many different Part D plans, but finding the one with a formulary that would cover the medications you're on can be difficult. So Medicare.gov will help you to find the right plan for you. Next slide. Now, Medicare Part B has a lot more requirements. Again, you're eligible at age of 65 or a couple of these other conditions that are listed below. The coverage is limited to specific outpatient prescription drugs. So we will see this in some oral cancer medications that are also available as injectables. We see it in vaccines, some transplant medications, and some nausea medications taken around the time of your chemotherapy. It's a very small list. A lot of patients do get confused why we're not billing their Part D, why are we billing their Part B, and it's simply just because that's what is on the Part B formulary. So this will cover 80% of the drug, and the patient would be responsible for 20%. Now, some people do opt to get a Medigap plan or a supplement, which would cover that additional 20% on top of that. The Medicare Part B prescriptions do have more requirements. You have to fill out paperwork the first time that you ever use your Part B in any pharmacy. It can't be, if I get it at my pharmacy and you go to use it even at another Publix, it wouldn't, you would have to redo the paperwork. Each time you pick up, you have to sign paperwork as well. The prescriptions are not allowed to be altered. So if there's anything missing on that script, if the directions aren't clear, we have to get a brand new prescription from the prescriber. They also require diagnosis codes, so that is something that we occasionally have to track down as well. And it's also not transferable. So we cannot transfer it from pharmacy to pharmacy at all. So then your doctor would have to send in a new prescription to that local pharmacy. Next slide, please. So next we have the manufacturer programs. I think we spoke a little bit about them earlier, but on an inpatient basis. So it's very much the same thing. There are free trial cards. These are usually designed to get the patient started on that medication right away while that prior authorization or appeal process gets taken care of. So it could be up to 30 days for approval, so you'll usually get a 30-day free trial on certain medications. There are also copay cards available. If your copay comes out to $50, sometimes this will bring it all the way down to $0. These can't be combined with federally funded programs, so not with Medicaid and not with Medicare. And then there are patient assistance programs, which are also based off of the federal poverty level. They'll completely cover the cost of drugs, but it does require some time to get approved. So each program is different. So some will ship the drug straight to you, some will ship the drug to the pharmacy to fill. And so that can also take up to 7 to 10 days to get the drug ready to dispense to you. Next slide, please. Next slide. Yes. All right, and then lastly, there are foundations and charities available. Each one has its own set of requirements. Some can be billed with insurances, some can only be billed with certain insurances, and it is usually drug-specific or disease-specific. So you may have to be using that drug for an indication that is FDA approved. And then there is also the Brain Tumor Copay Assistance Program, which covers $5,000 yearly, but you do have to pay for it up front, and then you submit your receipts for reimbursement. So you can quickly see that it can be overwhelming on just exactly how to bill each prescription. Hopefully this isn't overwhelming, but it lets you know that there are resources out there, and if you do have any questions, you can just come to your pharmacist, your resource specialist, or your case manager to help you navigate exactly how to get your medications paid. If all else fails and we've tried everything and the medication is not covered, we do have to reach out to your doctor to see if there is an alternative therapy. I look forward to your questions.
All right, thank you very much, Lauren. We have one more speaker in our panel, and that is Maureen Clement, who is the director of our Moffitt Medical Group. Maureen, welcome.
Can you hear me now?
Yep, we can hear you now.
Okay, great. Hi, so I'm Maureen Clements, and I'm the director of the Moffitt Medical Group, which is the physician group. It's a multi-specialty physician group that practices at Moffitt Cancer Center. So when I say multi-specialty, we have, I guess we're like a full service shop here at Moffitt Cancer Center, where we have complete cancer care treatment, kind of like under one roof, or maybe a few different roofs, but basically, you know, whatever you need for your cancer treatment can be found at Moffitt Cancer Center. Next. Next. So what I'm in charge of is I'm in charge of doing the physician billing. And Andy Talfer, who spoke a little while before, his team is in charge of the hospital billing. Now, this is where things can get really pretty tricky. At Moffitt Cancer Center, the vast majority of our physicians are members of the Moffitt Medical Group. We have a couple of different areas like cardiology, where we use a group called USF Health. But the vast majority of our physicians are members of Moffitt Medical Group. So when you come here, let's just describe like an inpatient stay. you will get one bill at Moffitt, and part of the bill will be related to the hospital, and the other part will be with the, related to the physician group. Even here, it can get a little bit tricky because there could be names on your bill that you don't recognize. For example, if you come here and you have a hospital stay, you're getting a surgery done or you're getting some type of procedure done. On your Moffitt Cancer Center bill, you're going to have hospital charges. Then in addition, you will also have charges from Moffitt Medical Group, anesthesiologists potentially, pathologists, radiologists, your surgeon. If you're staying here for inpatients, somebody who's in charge of doing hospital rounds, you could also get, you could see their name also on your statement. Now, a lot of times we'll have patients who will call our business office saying, I never was treated by this person, but you very well could have been. We also have physician assistants and nurse practitioners here. So while you may be being treated by a certain physician, you also could see the name of the APP if, or the nurse practitioner if they were also involved in your visit. Now, this can get even more complicated if you are getting treatment at a hospital outside of Moffitt, because many institutions do not have a full hospital-based physician group. So you can get a series of different invoices over a period of time, and you, like I said, you may not even recognize the name. So an anesthesiology group, you might not recognize the name, the pathologist, the radiologist. So it's really important to, when you're in that kind of situation, to follow up on all those different invoices. You know, at Moffitt Cancer Center, if you want to stretch your bill out over payment terms, like Andy was talking about previously, you can do that for the entire physician bill and the entire hospital bill. But at other facilities, or if you're getting some other kind of surgery done somewhere else, it's important to contact each one of those companies, physician groups, because you don't want to be delinquent on a bill that you think, oh, I took care of my doctor bill. Well, it might not have been that specific one. So anyways, this can get kind of complicated, but it's definitely important to make sure you follow up on all this. And you know, I know the names can be confusing. My son was just in the hospital a little while ago, and trying to explain all this to him was quite a handful. Next. Another thing that can even be troubling also is, you know, when you start out with a physician, you make sure that your insurance is participating. And so, you know, you go and you see the financial clearance department and you make sure that your insurance is accepted by that physician and at that hospital. But over a period of time, well, okay, so over a period of time, generally like at Moffitt, the hospital and the physician are both in network. At some other facilities, this can happen where, and especially like on something like a surgery, your physician or your surgeon could be in network. You picked a hospital that was in network, but something like might happen like where the anesthesiologist who helped on your surgery, they may be out of network. The pathologist who did the pathology reading on a tissue sample, they could be out of network. So it's just one of those things. I mean, you can protect yourself up front by, and like I said, Moffitt, we're lucky in that almost all of our physicians are part of the Moffitt Cancer Center. And even when, like we have a dermatology department and that can be a USF physician, but when you come in for an estimate, we can give you an estimate on the cost of those other providers. Some other times you may not even realize that your pathology that they're going to use is out of network. So it's very important at the time you come for a hospital stay, especially if it's somewhere else, that you make sure that your providers that you're seeing are in network, or that you're aware that they might be out of network, because you may be able to go to another hospital that that physician practices at, or you may be able to make special arrangements with your insurance company to pay more or pay something so you're not getting the out-of-network rates. It can be a surprise because, as you probably have seen before in some other type of treatment that you've had, if you use an out-of-network doctor, the costs that you have to pay are a lot higher. And I think Andy or Viviana was talking about reasonable and customary. So what happens is if you use an out-of-network provider, the insurance company still, in most cases, you have something called out-of-network benefits. But the insurance company, they will consider, the insurance company that is yours may consider those costs that that hospital or that physician is charging you as too high. So they're going to discount it and pay something, but it's going to be at a much lower rate than what you normally got a benefit for. So anyways, just be careful of that type of thing in the future and don't get caught off guard because it's a lot harder to fix it on the back end. So next. Yep, that was a quick one.
Great. Thank you so much, Andy, and all of our panelists. We do have time for questions now. So Andy, I will share the questions with you, and if you don't mind helping to direct them to the appropriate panelists to answer. For our attendees,
Sure,
as a reminder, thank you. So as a reminder, if you do have questions, please type and submit it via the chat box and send them to the ABTA, and we'll answer questions as time allows. So the first question we have here is asking, I believe earlier in the talk, Christy, you might have mentioned it about speaking with a financial counselor. So we have a question asking, how can someone get in touch with a financial counselor? Is that someone who's on staff at the hospital? Is that through another organization?
Yeah, no, actually, the financial counselor team largely reports to me. So they can get a hold of a financial counselor about those particular financial questions just by calling the business office of any hospital. If you get a bill and a statement, it almost always has the number of the business office on the bill. Those folks can help you. But if you haven't been treated yet, almost always on the website, there will be a financial section. And in that section, it will tell you, hey, here's a number you can call if you have any financial questions. So just sort of take that number and call. We at Moffitt actually do something as well on top of that, and we have what's called financial navigators, which can actually help folks. And I don't know, Viviana, do you want to give a plug for your navigator team? Because I think they're pretty awesome.
Yeah, sure. We do have two financial navigators. I can share the phone number, or I can send it to you, Emily, to share. And any questions that the patients have before coming to Moffitt or previous to enrollment, they can call. We can look for options. For example, Medicaid HMOs or Medicare Advantage. The financial navigators can explain to the patients the options. For example, Humana PPO and Humana HMO. Humana HMO is driven by the primary care physicians. So a primary care physician could say, no, I'm not going to allow you to go to Moffitt. But really the patient wants to come to Moffitt. So we offer options. We said you could switch from an HMO to a PPO. And the PPO, you can come to Moffitt. So we are available. Our extension is 7300, Moffitt 7300. Any questions, new patients or established patients with authorizations or insurance inquiries.
Thank you so much for that. Now, can you share advice or information on what patients and families should keep in mind when they're trying to choose the right insurance coverage for them?
Thank you. I muted myself and then I could not unmute myself. So just a warning to my peers out there. Well, I think we certainly can help walk folks through, some insurance. I think that there's a couple things that generally play into choosing an insurance. Number one, and I think Viviana and Maureen both mentioned it, make sure the places that you feel like you're going to need care are in network. That's really the first thing you want to do, is make sure that those hospitals are in network. Unfortunately, every hospital is not in network with every payer. It just doesn't work that way. The second thing you can do is look at what your out-of-pocket is and sort of what that policy will cover and won't cover. What is your deductible? What is your co-insurance? What do you think you're going to have from an out-of-pocket expense? And does that make sense for you in your lifestyle? And I think that's something that we can't really answer for you. Some people are very comfortable with a $10,000 deductible, and some people are not very comfortable with that. So just to understand, when you choose that payer, get it in network with where you really feel like you want to get care, and then kind of examine what you're going to owe based on the services you're probably going to have. Now, I answered all that, but I'm going to say, Viviana, you're still the expert on this. So is there anything you want to add?
Now, I'm muted now.
There
Yes.
you are. Yeah.
No, very important. If you do not have to know if your insurance is going to pay for the services, because we find a lot of policies that are limited policies. So they could pay for an emergency, but they could not pay for cancer treatment.
Yeah, good point.
Thank you for answering that question. In one of the presentations, you spoke about the copay assistance program. We have a question here asking if someone wanted to enroll in such a program, how can they do that? Is it through the hospital, or how does that work?
Viviana, that's you.
Thank you. Yes, we will help the patient enrolling. So the patient can reach out to us, the financial clearance unit, or we can reach out to the patient. What's happening now, when the physician is ordering the treatment, they are signing the paperwork immediately with the patient at the clinic, and we are receiving that paperwork, because many manufacturers, they ask for signatures, not electronic, but paper signatures by the provider and the physician. But they can reach out to us, 7300, or reach out to the provider, and we will enroll the patient in the programs. We'll do it on behalf of the patients.
Great, thank you for that. And this question is about prescription medicine. Is there a way that a patient can check if a medicine that they're being prescribed will be covered by their insurance before that becomes part of their treatment plan?
So, Lauren, would you like to kind of chime in on that one?
Yeah, you can always call the insurance company directly. Nobody ever really wants to do that because you're on hold a very long time. Honestly, the quickest way is just to get that prescription in the pharmacy. It only takes like a minute or two to type it up, and I can tell you immediately whether it's covered or it'll require a prior authorization. But otherwise, you can call the insurance company directly.
Great, thank you so much for that. And another question we have here is, what is the process like to apply for financial assistance or financial aid? Does that have to be done through the hospital, or does it require the patient kind of having to be their own advocate and finding the right financial assistance programs for themselves?
Okay, I think I can answer that. Most of the different facilities have a financial assistance program that is out there, and it's pretty clearly listed on their website. So what they will write off and what kind of assistance they will give is usually pretty documented. Most of the time, to be honest with you, what I have, most of the struggle we have at Moffitt anyway, with folks who are trying to engage us with financial assistance, is they don't provide all the necessary documentation that we have to approve their application. So what I would ask, and this would go with every provider you may go to, is to look very closely as to what the required documentation is when you apply, and make sure you have that make sure you have all that documentation. You can always call the business office and say, when you say I need to prove my residency in Florida, I have a TICO bill, will that work? And at Moffitt, we will say yes. But some other places will say, no, we need to see something like a lease or a rental agreement or something like that. So really, it's just look online, educate yourself as to what is necessary to apply, and then it should be fairly easy from that point in time. The little stat that I always sort of throw out, 92% of people who are not approved for financial assistance in 7 days at Moffitt did not submit all the paperwork. And what we're doing is we're asking them to please come and give us one more piece of documentation so that we can process their application.
Thank you so much for that, Andy. Now, for patients that may be denied financial assistance initially, are they able to reapply later?
Most certainly. Yep. Yeah. Some facilities will say, you know, they will put a time in there to say you can't apply for 90 days or 6 months, but almost all of them have a policy in there that says, look, if you've had some major change in your life, they will kind of waive that, even that rider. But at Moffitt, if you're denied, you can reapply. The first thing we're going to ask you is, what, you know, help us understand what's different about when we first talked. So.
Awesome, great, thank you. And can you share advice on what patients can do proactively to better understand what their out-of-pocket costs would be prior to having a test done or prior to starting a treatment? That way they can better prepare.
Yes.
Sure. Viviana?
Very important, they could call their insurance company to understand how much is their out-of-pocket and what is the remaining. And also to understand what is the benefit period, meaning some insurance companies run from January 1st to December 31st, but other companies ran from July 1st to June 30th. So that is going to make a difference, because if you are going to start treatment in December and you're responsible for $5,000, you're going to end up with $10,000, correct? $5,000 for the current calendar year and $5,000 more when the new benefit year starts. But they can always call us, the financial clearance unit, and we can provide that information, because we are going to know, okay, sometimes the charges are not relevant, especially if we're talking about cancer treatment, because if my out-of-pocket is going to be $5,000 or $6,000, I'm going to meet $5,000 or $6,000. If I'm going for a radiology test, yes, it's going to make a difference if what is the charge of the hospital or of the freestanding facility. But usually for cancer treatment, just to know how much is the out-of-pocket is going to provide that information.
All right, and I think we have time for one more question. This goes back to, I believe, Andy, this was in your talk where you talked about the federal poverty level. How can someone determine what their federal poverty level is or where they're at?
You can go to the Department of Health and Human Services out on the website. There is actually you know, an indicator on there. I think you can actually plug numbers in and it will give you your percentage. The only thing that I would ask about that, though, is when you're really trying to apply it to financial assistance, there's a numerator and a denominator on that. And the first is how many people are in your family, and then the other one is what's your income. So I think you remember from my presentation, a lot of facilities have rules around what they call income. And so what one facility may call income, another facility may not call income, and that will change your number a little bit. So if you are interested in financial assistance at a facility, probably the best thing to do is apply and say, I feel like I need some help. I would like to apply for financial assistance. They will all have that FPL sort of listed, but based on what they're, calling. Now, for those folks who are pretty straightforward, they're, on a very limited income, they get one check from SSI or something, then it's pretty easy to do. But if you have assets and you have a retirement and you have some other stuff, then the best thing I would say is if you think you qualify, apply, and we can talk through.
All right, wonderful. Thank you so much, Andy, and thank you again to all of our panelists. That's all the time that we have for questions for this session. I'm going to go ahead and turn it back to Emily. Thank you.
Yes, thank you so much for each of our panelists with sharing with us how to maintain financial wellness during brain tumor treatment. And thank you to all of you, for those of you who asked their questions and we were able to learn some further information. Although the ABTA does not provide financial assistance to its constituents, our website has links to a number of organizations that do. These cover a variety of costs such as medical bills, household expenses, and travel and lodging during treatment. Please note that each organization has different eligibility requirements. You can find more of this information on our website at www.abta.org/financial assistance. This now concludes the American Brain Tumor Association's online educational regional patient and family meeting in partnership with Moffitt Cancer Center. Thank you to all of you for joining us on the web today and being a part of this community. We hope you have found our sessions to be full of new information, resources, and support. Each of you will receive an email requesting you to share your feedback with us and fill out an anonymous survey. We encourage each of you to take some time to share your feedback with us. We are here to serve you, and your feedback is crucial to enhance future programs and ABTA's mission. I would like to thank once again Moffitt Cancer Center for partnering with us on this meeting. Thank you to our program planning chair, Dr. James Liu, for your support during the planning and execution of this meeting. We would not be able to have done this without you. Additionally, I would like to thank each speaker for taking the time out of their day today to share their insight and expertise. I would also like to thank each of our sponsors, Novacure, Orbis Therapeutics, Integra Foundation, GT Medical Technologies, Boston Biomedical, and Navio, and also to our funder, Genentech, for all of your support of this event. And most importantly, I thank each and every one of you for joining us online today. We hope you have found our virtual meeting to be informative and helpful. Be sure to be on the lookout for our upcoming meetings, events, and webinars found on our website at abta.org. Thank you again for joining us and enjoy the rest of your day.